possible. And we put today into your hands. Pray that you go before us, give us wisdom. May this day be a success. In Jesus' name we pray.
Amen. Thank you so much, Beatrice. Today is our third day of the first Kofih Health Forum. Over the past 2 days, we've been looking at different themes. All of them are pointing to turning health challenges into opportunities for change. And today we are glad that we are rounding up this discussion with still a series of more discussions just to make it more rounded. And we are glad that most of our presenters are on their way coming. So we're going to have a little change in the program, and we're going to be beginning with government and partner interventions in infectious diseases. Dr. Emmanuel Tweyongere is going to be giving us this presentation. Dr. Emmanuel, you're welcome. So we're streaming these presentations, so we know some of our colleagues are online watching, even though they are not yet in the room.
I think the topic was also changed. It's burden of infectious diseases. With the remote. It's a presentation. Yes, it is.
He's going to be moving the slides.
Okay. Let him go back to slide number 1. Yes, good morning. I'm Dr. Emmanuel Tweyongere. I come from the Department of Communicable Disease Prevention and Control, precisely National TB and Leprosy Program. Our department is the biggest, as I told you earlier. We have different divisions. We have TB and leprosy division. We have malaria elimination division. We have ACP, we have UNEP, and so many others. Chair, I don't know why you made me even come in front. I would have presented while seated, because we are just a handful of us here, but it's okay. And I hope as I present, more people join us. So my task is very simple. We're supposed to talk about burden of infectious diseases in Uganda. We have so many infectious diseases, but I just chose a few, the major ones. TB, HIV, and malaria. These are diseases targeted for elimination in Uganda. As a department, we have a vision, and our vision is a Uganda free of vaccine-preventable diseases, tuberculosis and leprosy, malaria, and HIV/AIDS. So we want a Uganda which is free of these infectious diseases. And our mission is to provide quality, accessible, and affordable prevention and care services for communicable diseases to all population groups in Uganda. And you should mark our words, to all population groups in Uganda. Our ministry believes that for as long as you're in Uganda, whether you're a foreigner or even stateless person, but for as long as you're in Uganda, you should access our services, which may not be the case when you go to some other countries. For us, for as long as you're here, it doesn't matter who you are. It doesn't matter your nationality, refugee, foreigner, stateless. You should be able to access our quality services. Next. Ladies and gentlemen, as a department, we've got a strategic direction where we have a strategic goal and strategic objectives. Our strategic direction is to enhance and strengthen accessibility and utilization of quality integrated communicable diseases prevention and care services. So for us nowadays, everywhere you go, you must talk about integrated services. We no longer have outreaches only targeting UNEP activities or TB activities. When someone is going for an outreach to immunize children in the community, we expect him to carry HIV medicines for some of these patients. We expect them to do contact tracing for TB contacts. So our approach is integrated services. And we have 4 objectives. Number 1 objective, as a ministry, as a department, we want to ensure that every child and high-risk group is fully vaccinated with high quality and effective vaccines against the target diseases according to the recommended strategies. Objective number 2, we want to achieve 0 malaria death. No one should die of malaria. But also want to achieve more than 75% reduction in incidence of malaria. Number 3, we want to reduce TB incidence by 6.5%. Right now we are standing at 198%. So we want to come from 198 per 100,000 population to, and also proportion of children from 14 to less than 3%. Ladies and gentlemen, we still have leprosy in Uganda. And over time, we've stagnated between 14, we're oscillating between 14 and 6%. So we want to go below 3% for leprosy notifications. And objective number 4, we want to reduce HIV incidence and mortality by 50% by 2030. And here we're working towards ending AIDS as a public health threat. Next slide. So now that we've known our strategic direction, the strategic objectives that are guiding us in all activities we do, let's look at individual diseases. Burden of TB. Ladies and gentlemen, Uganda is among the 30 high burden TB and TB HIV countries. So we are about 154 countries in the whole world. And Uganda is among the top 30 high burden countries when it comes to TB, but also TB HIV co-infection. You can imagine what we are contributing to the whole world. Estimated cases of TB are about 96,000 per year. And just last year alone, we were able to get 94,000 cases of TB. The national 2014-2015 prevalence survey, we last had a survey 10 years ago. And that survey put TB burden in Uganda at 253 per 100,000 population. Simply put, for every 100,000 people you meet, 250 of them have got TB, which is a big burden for us. The incidence of TB right now stands at 198 per 100,000 population. So as you move around Kampala or any other part of the country, If you count 100,000 people, 198 of them will have TB. And every day, we get about 249 new TB cases. So these are about 10 cases per hour. As we sit here, someone is getting TB in our country. And unfortunately, we still lose a significant number of patients to TB-related death. And every day we lose about 27 people to TB. So these are 2 taxis of people dying every day due to TB-related death, which is quite unfortunate. Next. Our children account for 15% of the notifications. Of all TB cases we get in Uganda, 15% of them are children. And for us in the programming world, on the ministry, we're looking at children between 0 to 14 years. That's how we categorize children. And annually, what we are seeing, we are getting about 700 cases of multi-drug resistant TB. And we know MDR TB is a TB which does not respond to usual drugs. It is quite expensive to manage. One patient of MDR TB can actually cater for about 5 patients of DSTB or drug-sensitive TB. And 37% of our TB patients have also got HIV. So the TB-HIV co-infection rate right now stands at 37%. However, there is regional variation. When you go to Ankole region, co-infection rates are about 48%, meaning that almost 50% of our patients who have TB have also got HIV. But when you go to Karamoja region in eastern Uganda, the co-infection rate as per last quarter is at 5%. So there is regional variation, but on average, 37% of our patients of TB have also got HIV. What we've seen over time, and from our data, is that TB is 4 times more prevalent among men than women. So whenever you see a woman having TB, just know there are 4 men who have TB. Unfortunately, men don't want to come for services. And we have also seen that TB is more prevalent in urban or cities compared to rural areas. So as we sit here, as we stay in Kampala, urban areas, cities, we stand higher risks of getting TB compared to our parents in the villages. And the reasons are simple: congestion, slum areas, drug abuse, and so on. Now, 53% of Ugandans who suffer from TB also suffer from what we call catastrophic costs. What it means that about 50% of our patients who suffer from TB spend more than 40% of their annual income on TB-related treatment. We know TB treatment or TB services are free in Uganda, but there are hidden costs. When someone is going to clinics to pick medicines, he's spending money. Even before a diagnosis of TB is made, that person has been moving around, being treated for cough, for pneumonias, and so on. So most of our patients actually spend a lot of money on TB-related treatment indirectly. Next. Socioeconomic impact of TB. When someone is sick, during period of sickness, what happens? There is loss of income. Most of our people here are daily earners. If you don't work today, you don't get a single coin. So when someone is sick, he's not going to earn. So there is loss of income. There is also increased medical expenses. As I said earlier, most people may not come directly to us to be screened for TB. So they first move around. As he moves around, he's spending a lot of money before a final diagnosis of TB is made, and then he gets the right treatment. But also for children, you've seen that 15% of our patients of TB are children. There's also missing school. The child may miss school because that child is sick, but some may also miss school because they are taking care of the sick. When your mom is sick or your dad is sick, you may not go to school because you have to take care of him or her. Now, death, of course, as I told you, we lose about 9,900 patients TB-related death. During death, there are funeral expenses. When that person dies, obviously, as a family, you're going to spend your money during the burial processes. But there's also permanent loss of income. Imagine that person who dies is a breadwinner. The moment he dies, the whole family is plunged into poverty because the breadwinner has gone and no more income. But because of TB, we have also seen increased vulnerability of households. So there's less money for food because the breadwinner is not working. When you don't have food, obviously, nutrition is impacted on. And we know malnutrition predisposes you to TB, so it's a cycle. Less money, malnutrition, then you again predisposed to TB. All your family members are now predisposed to TB. There's also less money for healthcare on family health, but also less money for education. And you know, right now, if you have not gone to school, survival is becoming harder and harder in any part of the world. So imagine children who are not going to school, they are becoming school dropouts, and that will lead to severe loss of future earning potential. Yeah? Even any kind of job nowadays requires basic education, the askari, even housemaids. You need to have some basic education. So if your children drop out of school because of TB, then in future, they will not be able to earn a living. Next. Briefly about HIV. Currently, 1.5 million people live with HIV in Uganda as of 2024. And the HIV prevalence right now is at 5.5, slightly more in women at 6.9%, and men at 4.2%. We have about 70,000 cases of children who have got HIV. These are innocent souls that have been infected by their parents. We see gender disparities. Young women, and we are looking at age of 15 to 24, are 4 times higher than their peers. So if you compare young women and young men are likely to have HIV compared to young men. And the reasons are simple. Yeah? That age group is very sexually active, very attractive to men who have the money, and that kind of peer pressure, trying to hold very smart, good phones, live a good life. So it ends, that kind of peer pressure ends up putting our young ladies at risk of getting HIV. Next. Let's move. Okay. In terms of new infections, I want to report that we've decreased new infections from 100,000 in 2010, and currently we are at 36,000. Now, in terms of AIDS-related death, again, as a country, we've greatly improved from 55,000 in 2010 to 20,000 in 2024, which is a very good improvement. But our target is that we want to have it moving between now and 2030. Unfortunately, we are seeing more infections. Go back. We are seeing more infections in terms of death, compared to death. So we are losing more people. We are losing less people, but we are getting more infections. Okay? Why? Because our ARVs are working, so more people are living, but we are supposed to reduce infections if we are to control HIV in Uganda. Less people should get infections. The key drivers of HIV infections are adolescent girls, okay, and young women. These ones are causing us a toothache. But we also have key populations, like people who inject with drugs, okay? Substance abuse. I recently visited Butabika. I'd just gone to see a patient. But I was surprised by the number of young people I found in that drug abuse unit. So many people, so many young people. Women, men, boys, and so on. And surprisingly, I also found a number of health workers. Some even at a very senior level. Very disturbing. Then we have got sex workers. I think as we move forward, the number of sex workers is becoming more and more, which is also quite unfortunate. Of course, we also have high-risk men, like truck drivers. We also have people who don't want to adhere to poor retention. Someone starts treatment today, he gets better after 1 year, then he drops off. And that poses a risk to the people he's going to have sex with. And we also have gaps in prevention of mother-to-child transmission. So these are key drivers of HIV infections in Uganda. Next. In terms of geographical distribution, I'm sure most of you read papers, you watch social media. Central and southwest Uganda have got the highest prevalence of HIV in the whole country. And particularly, we are looking at districts like Rakai, Masaka, even Kampala, where most of us are staying. So as you try to make yourself happy, please be reminded that HIV is moving around. So you have to be cautious, okay? Northern Uganda and Eastern Uganda have the lowest prevalence at less than 3%. Karamoja, Teso, and Lango. But also Karamoja, when I used to go, when I just joined the ministry, I found the prevalence very, very low at around 1.5 in Karamoja. But as time goes on, it is becoming also worse, increasing slowly. Okay? I think as some areas become more modern, people are more exposed, foreigners come, and they are now infecting our Karamojongs. We also have high incidence districts for adolescent girls and young women. Ladies, men, when you go to Fort Portal for tourism, be reminded that those young ladies have HIV. Not all of them, but the HIV rates are quite high in Fort Portal City, Chotera, Bunyoro, Kampala, and also Soroti, Okeba. Our district is becoming a problem. I don't know the biggest driver there, but okay. Next. So you've heard of 95. Currently, 94% of people living with HIV know their status, and only 94% of diagnosed patients are on ART. The good thing is that those on ART, 97% of them have virally suppressed. Again, we are seeing gaps in men. Only 87% of men are on ART. So you can imagine the 13%. It's outside there, freely spreading HIV. Children, only 67% of children on ART, and 89% are virally suppressed. So we need to reach out to men. Men don't want to come for services. Even when they find out that they have HIV, they don't want to be put on ART. Some continuously live in denial. Next. So as we target our epidemic control by 2030, we are looking at high impact interventions, and here we want to integrate and scale evidence-based prevention and treatment services. We want to have a geographical focus, equity. We want to direct resources to high burden regions and hotspots. We want to integrate person-centered care, where we want to link HIV with sexual reproductive health, TB. As you've seen, the TB HIV co-infection rate is at 37%, but also goes beyond 40 in some regions. We want to integrate with NCDs, mental health, and so on. But most importantly, we are looking at multi-sectoral implementation. So we are engaging the public, private, civil society organizations, but also the people living with HIV in Uganda. So it's a multi-sectoral approach. We, as health workers, we cannot manage HIV epidemic alone. We must bring on board different stakeholders. Next. malaria, which is well known by almost every Ugandan. Malaria is the leading cause of ill health, okay, and death, and it costs about 3% of annual income per episode to each family. Just last year alone, malaria contributed 20% of all OPD cases in Uganda, and 17% of all admissions were due to malaria. It still contributed 4.7 of all causes of death in Uganda. So you can imagine the number of people we are losing to malaria. According to World Report, World Malaria Report, Uganda contributed 4.7 of global malaria cases. Out of 154 countries, we contributed 4.7% of global malaria cases. That's a very big percentage. And if you look at absolute numbers, again, the numbers are high. We also contributed 2.7% of global malaria mortality. Of all people dying of malaria, Uganda contributed 2.7%. These pictures may look scaring, but I want to assure you that we have come from far. Malaria cases reduced. The good thing that malaria cases reduced from 12,651,000, which was about 5.1% of global cases in 2022, to 12,573,000 in 2023. So there is an improvement. We still have so many cases, but at least cases are reducing in terms of numbers, but also the percentage we are contributing to the whole world. Next. I also want to report to you that malaria death reduced from 16,416 in 2022 to 15,363 in 2023. So in terms of cases we are contributing, in terms of death we are getting, the numbers are coming down. Consequently, Uganda takes the 3rd and 9th position in contributing to global malaria cases and death respectively. So these are positions we can never be proud of. Okay, but it's a reality. And the reason as to why we're here is for us to discuss and see how we can end these epidemics or infectious diseases in our country. Next. So among the infectious diseases, we have also got what we call neglected tropical diseases. And I just singled out leprosy. Why? Because most of us have forgotten about leprosy. But as you can see from the data, we still have leprosy cases in Uganda. Just last quarter, July, September, we got 72 cases of leprosy. And you know, leprosy is the oldest disease, very stigmatizing. Most of our cases you see here come from West Nile, okay? For example, Terego district alone, in 1 quarter, gave us 14 cases. And 13 cases also came from Koboko. But we have also got leprosy from other regions and districts, like Mayuge district, which is not far from here. It gave us 9 cases. Kumi district in Teso region gave us 6 cases. The reason as to why we have many cases in West Nile is because of the surrounding countries, South Sudan and DRC. We have so many refugees who come from that area. And sometimes they're started on treatment, they never complete, and they go back. And then come back when they are worse. But we're currently having engagements with our counterparts, and we think the picture will change. Next slide. So in terms of disability, when you get these cases, like 72 cases you saw, 30% of them had grade 2 disability. And we talk of grade 2 disability, it means someone has got visible complications of leprosy. These are people who have got wounds that have not healed, their fingers may have fallen off, or sometimes you find someone whose eyes cannot close. Unfortunately, some of these complications are not reversible. We can only rehabilitate, we cannot reverse the damage which has been caused. Next. So ladies and gentlemen, I want to remind ourselves here that an infectious disease anywhere is an infectious disease everywhere. And the best example we keep on using is COVID. Started in China, but ended up in Masaka, ended up in Kabale, ended up in Karamoja. Okay? So for as long as you have an infectious disease anywhere, you can never be safe. No one is safe until all are safe. And that's why as a country, as a ministry, as a department, we cannot work alone. We're engaging our neighbors through cross-border engagement. Thank you for listening to me. I wait for your questions or recommendations. Yeah.
Thank you so much. So kindly, I'm going to request you to note down the questions that you're going to ask him. We will ask him briefly after we've listened to our keynote speaker. Our keynote speaker today is none other than Dr. Robert Kalyesubula. Is the chair of the Department of Physiology at Makerere University, President Emeritus of the Uganda Kidney Foundation, a nephrologist and an expert in NCDs. Please, let's welcome Dr. Kalyesubula to the podium.
Thank you very much, MC, for the invitation. Good morning, ladies and gentlemen. All protocol observed. Can I have the presentation, please? Thank you very much. So I'm going to be talking about the challenges and opportunities for change in non-communicable diseases. Next slide, please. So I'll be talking about the WHO global tools, then talk about what NCDs are like across the world. Then I'll talk a little about NCDs in Uganda. I'm aware that Dr. Mtunji is going to be giving a presentation, so I'll just focus on a few of those. Then I'll delve into opportunities and challenges and share a few examples of what has worked, and then talk about a few of the next steps we could be using. Next slide. I'll start with a medical case. I'm a kidney specialist, so I see many of these individuals. And unfortunately, non-communicable diseases don't seem important until they strike you or a member of the family. This was a 25-year-old man who was actually going about his business, but then when he presented to Mulago, we soon found out that he had a kidney problem. And to make matters worse, we discovered that he was actually in stage 5, which we also call kidney failure. Now, when your kidneys fail to work, you have about 3 options. One of them is dialysis, the other one is a kidney transplant, and the third one is actually conservative management, which leads to death in about 1 to 3 months. So the family put resources together, and this young man was initiated on dialysis. As I'll be sharing with you, dialysis is very, very expensive. Doctor was talking about catastrophic expenditures. Non-communicable diseases are one of the leading causes of catastrophic expenditures, driving families into poverty. So this young man actually needed about 800,000 shillings per week in order to keep on dialysis. Soon his funds actually ran out, but I'll be sharing about this story in the end. Next slide, please. So Uganda has several policies and to guide non-communicable diseases, and these actually have been put up. Some are still in development. We have a multi-sectoral strategic plan for non-communicable diseases, and these actually guide the implementation of what we do for NCDs. And there are several stakeholders, including NGOs, the civil society, the academia, and international partners that actually support non-communicable diseases. Unlike infectious diseases, non-communicable diseases have not received as much support and financing, largely for the reasons presented above. Non-communicable diseases are usually borne by the individual and are rarely transmissible to other members. So the international community feels safe if you stay where you are, as opposed to infectious diseases. Next slide, please. So, but the World Health Organization has given us some best buys for prevention and control of NCDs. These are often low-hanging fruits that countries can adapt, and Uganda has played a very good role. For instance, we have a tobacco control program. We have also a policy there. We have also looked at harmful use of alcohol. That's why you see every year the taxes on alcohol keep getting higher, but people continue to consume. I think people who take alcohol are usually having some spare money to use. Unhealthy diets, as I'll be sharing, this affects most of us, especially those who live in big towns. And then the physical interventions for major non-communicable diseases. The issue about non-communicable diseases is that they actually share the risk factors, and if you try to reduce those risk factors, you are protected against most of these diseases. Next, please. Next. So, next, please. So, we now talk about the leading causes of death globally. By 2019, we had high blood pressure as the major risk factor, and smoking, and high blood sugar. But just recently, about a month ago, the Lancet Global released the new leading causes of mortality globally. And you can clearly see that high blood pressure, the dietary risks we talked about, and now there is a new player, which is actually air pollution. I'm not going to be talking about all this, but being a nephrologist, you can also see that among these, kidney dysfunction is the 7th leading cause. Next slide, please. Yeah. So I'm going to come down to Uganda. We had a survey which is based on the WHO criteria. The first one was in 2014, and another one was done in 2023 to show what is locally available. So they found that high blood pressure was present in 24.3% in 2014 and increased slightly to 24.5%. But the high blood pressure actually went, the high blood sugar, which is also diabetes, doubled in this period of about 10 years. And then also overweight and obesity actually also increased. These are metabolic things which are largely in our control, but we can see that they increase. Next slide, please. We can also look at this is disturbing my flow a lot. Is there anything I can do to have some control of my slides? Yeah. So the risk factors and recent trends, again, you can see that the key drivers, again, tobacco, harmful use of alcohol, unhealthy diets, physical activity. But clearly you can see that the key things that have actually increased is the current use of alcohol. People continue to consume alcohol. And then what is the biggest problem here, which you would actually expect that would do better, is the consumption of fruits and vegetables. These have remained high. Very few people actually access these vegetables. And I won't be talking very much about them, but vegetables are very important in reducing most of the non-communicable diseases because they help to lower blood pressure, they help to reduce cancer, and they help to reduce diabetes as well. So it's very, very important that we actually begin to think about our dietary habits. Next slide, please. This is a study we did in Mulago and published the work in 2019. It's quite a complex graph, but if you can move with me on that would be your left side, my right. The panel there is comparing infectious diseases and non-communicable diseases over a period of 4 years. It's an old slide, but it speaks it all. You can see that the infectious diseases are actually much more than the non-communicable diseases at the beginning, but they were actually declining as causes of death over that period of time. But you can clearly see that the non-communicable diseases like hypertension were on the rise. And on this panel, we are actually breaking down the age groups, and we are showing that even beginning at earlier age groups, there is increased mortality across the different non-communicable diseases, starting as low as 20 years. We looked at people above 18 years. So it's important to appreciate that the burden of non-communicable diseases is actually increasing. And we looked at about 50,000 individuals. So this was actually a very big sample size. Next slide, please. When we look at diabetes, we know that over 537 million people are living with the diabetes, and this is projected to increase by about 30% by 2045, and Africa bears a big burden of these diseases. And when it comes to Uganda, I just showed you that in 2014 we had about 600,000 individuals, but this has gone up to about 1.5 million. But 50% of these are actually undiagnosed. Next slide. So when it comes to Uganda, next slide please. When it comes to Uganda, there's actually no major significant difference between the rural and the urban in the prevalence of diabetes, but overweight and obesity have increased, as I shared with you earlier. But about 45% of these people who have diabetes actually don't know that they have this condition. And the majority of people present late. Next slide, please. When it comes to the issue of hypertension, we know that about 1.5 billion individuals are living with hypertension. Next slide. And again, Africa bears a very big burden of this disease. As I showed you earlier, about 24%, every 1 in 4 people have hypertension. And in a study we did, there's also regional difference between the different parts of Uganda, with central Uganda having 1 in 3 people having hypertension. Next slide, please. When it comes to kidney disease, we know that over 800 million people have kidney disease worldwide. And 1 in 10 people, that means 10% of people who are adults have kidney disease. And kidney disease is projected to be the 5th leading cause of death. And that's actually by 2040. When it comes to sub-Saharan Africa, we have a slightly higher prevalence of about 13%. But what is most worrying is that 90% of people living with kidney disease don't know that they have it. And even those who have it, in the next graph you are seeing, they actually often don't get adequate treatment because of the reasons I shared earlier. Next slide, please. So when we are looking at kidney disease, it is actually comes into 3 modes. You have what we call the acute kidney injury. Then we go to the acute kidney disease and then the chronic kidney disease. The issue about this is that kidney disease can largely be reversed if people are discovered early. But if they are not discovered early, then they end up getting cardiovascular complications and end up dying. And we have peculiar risk factors in our settings, like pregnancy, genetic predispositions, other diseases like sickle cell disease, which are not commonly available in other countries, and then ultimately other exposures where people get snake bites, they get malaria. So the infections play a big role again into causing chronic kidney disease. Next slide. So we have also tried to map the prevalence of chronic kidney disease in Uganda, and it differs. We don't yet have the explanations why this is the case, and for some areas we actually haven't done population studies. Next slide, please. So, next, please. So what is also very critical is that we looked at about 217 individuals who presented to our clinic in Mulago Hospital. And we noted that over 50% of the people who presented to the hospital came in end-stage kidney disease, meaning that they would need dialysis to save their lives. So that's the key point, that people present very late to the hospital. Next slide. And this is just what I shared a bit earlier, but a bit of detail. If someone goes into kidney failure, presents in stage 5, they would actually need dialysis. And this is how much it costs. I should have converted it to Ugandan shillings. But in order for you to get dialysis, you actually need an access to your blood vessels, and they have to put a catheter. That catheter costs about 800,000 in the government institutions. And if you need a permanent catheter, it costs between 1.5 and 2 million just to get you started. And then you need weekly dialysis, which costs about $90. That's about 90 times 4, about 300 per week. And of course, there are other drugs that drive this cost much higher up. Next, please. And if you looked at the current earning of our medical officer, who earns $1,000 per month, so a medical doctor living in Uganda, paid by the government of Uganda, will not be able to afford dialysis. And you know you hold doctors in high regard. So that's what it means to have kidney disease. Next slide, please. But we have worked together with the Ministry of Health and AstraZeneca and actually set up guidelines for management of kidney disease. They will soon be unleashed. Next slide, please. Now, let's talk a little bit about the things for non-communicable diseases that probably will affect you people who are seated here. I know we always talk about smoking, alcohol intake, lack of exercise, but we now know that actually sedentary lifestyles are very bad. Next slide, please. So I want to present to you that the new elephant in the room, especially for you people, is sitting. And we say that sitting is the new smoking. And I will illustrate this for you. So most of you work in offices or you come to conferences and then you sit. So you end up sitting for about 8 hours a day. You wake up in the morning, you shower, you drive. If you wake up early, you take a minimum of 30 minutes. But if you come late, you'll end up spending 1 hour in the jam. Then when you reach office, you sit on your desk for another about 3-4 hours. And then you end up going back home again in the jam. When you reach home, there's usually some unfinished business. You're a good guy, so you take a shower and maybe you jog. Then you come back and watch those latest series. So you end up sitting for 8 hours, and that would translate to about 116 days per year of sitting. So we know that that actually translates into non-communicable diseases, which is equivalent to smoking. So you people who are elite, please watch out on that issue of match sitting. I thought I would highlight that for you. Next slide. Of course, the Ministry of Health has also been very gracious, and recently the Health Ministry launched physical fitness guidelines. But I'm sure many of us have not heard about them, and we actually probably have not set up these policies. So as non-communicable diseases affect us at individual level, and we have to begin developing behaviors as individuals. You can see there Golola, who was showing people how to do exercises, but you don't need to be like Golola. You can actually just establish a pattern. We now need about 30 minutes every day of moderate exercise, but there's also evidence that if you did very aggressive exercise, you could actually do that for 20 minutes. And that's very little time, especially if you have a routine. You don't need to go to the gym. You can just run around your home. Of course, you need to create safety spaces for people to be able to jog. Next slide, please. Now, there are some challenges for NCDs in Uganda, and these actually stem mainly from the weak implementation and financing, especially the national plans. Then we have also limited primary care capacity for NCDs. The NCDs have not yet percolated the primary health care because they usually need another step of being able to be diagnosed. In order to diagnose blood pressure, you need a blood pressure machine. In order to diagnose diabetes, you need a glucometer. And so that has been hard to take to the lower communities. We also don't have good data surveillance as opposed to what happens in the infectious diseases. And then most of our services are fragmented. And then we have a lot of health workforce shortages. I can tell you that we only now have 14 kidney specialists looking at after 48 million. And I'm sure it is the same across most of the non-communicable diseases. And then we also have the issue of social determinants of poverty. A lot of people are coming to town, riding borders, and then most of us, as I've shown you, we spend most of our time seated, and these health determinants actually continue to drive non-communicable diseases. Next, please. So the next steps, I'm going to try to share what has worked locally. I know we have developed some policies which I shared earlier, but I'm also going to share some few stories of where individuals can make a difference. Next slide, please. So we have a program which is based in Nakaseke. It is called the Balamu and Impide NCD project. And this was based at integrating and scaling up NCDs in Nakaseke district using the community health work model. Next slide, please. This is where Nakaseke is located. It is actually about 60 kilometers from Kampala, and we worked in the 3 sub-counties of Kasangombe, Nakaseke Town Council, and the Nakaseke sub-county. Next slide, please. We went to the community. We are a community-based organization focusing on health, education, and economic empowerment, and we actually asked the community how they wanted us to manage non-communicable diseases. Next slide. This is the model we used. We actually went and engaged the community health workers. We conducted VIS and then did health education. And then later on, we actually initiated NCD testing using community health workers. Next slide. We actually improved and expanded NCD access. We are able to work with the government to set up 3 non-communicable disease clinics, one in Semuto and one at Nakaseke Hospital, and then we also set up one at Access. We trained 20 community health workers, and we are able to screen 16,000 individuals for self-reported non-communicable diseases. We also developed simple pocket doctor handbooks, which were translated in Uganda, and these were very well understood because they had illustrations. You can see there the people actually liked this and kept engaging while learning. Next slide. And this is the Nakaseke hospital with whom we worked. We used the WHO Pen Plus guidance, and we are able to actually work with Nakaseke. Next slide. Next. Next. So these are some of the pictures that showed our engagement. Next, please. That showed our engagement, training community health workers, engaging community members. Next, please. And training the health work providers themselves at Nakaseke Hospital. Next. And so we trained actually the community health workers to be able to screen for risk factors, which I shared up. They were able to take the blood pressures themselves, take weight and height, measure the blood sugar using glucometers, and also use a urine dipstick to be able to determine kidney disease. And then they collected this information and transmitted it. Next slide, please. So we are able to screen about 3,600 individuals. This is one of our community health workers who was actually using a dipstick to tell whether someone has a kidney problem. Next, please. And we actually were able to get this information. We noted that kidney disease was prevalent in about 4.5% more in the males. Then diabetes was close to the national prevalence, although people had a lower prevalence of about 1.5. And then hypertension in Nakaseke was actually a bit higher, with 1 in 3 individuals. On this side here, where the comorbidities, not so common, but about 0.2% had actually all the 3 diseases. Next slide. Of course, that program shows that if you have an initiative, you can go to the lowest level, including community health workers. Now, of course, the current adage now is integration with limited funding. We really have to integrate our services, and the Ministry of Health has taken this. Next slide, please. So I want to share with you the work that has been done by the MJAP, which is a program looking after people with HIV/AIDS. Sometime back in 2015, we actually did a study and showed that the prevalence of hypertension among people living with HIV was quite high, with 1 in 4 people having HIV but did not have treatment. Next slide, please. So the group set out to implement a study which were to screen all people living with HIV for hypertension at the ISS clinic, and to try and initiate these individuals in at least 90% of all of them, as those who are diagnosed with HIV. They also wanted to improve the blood pressure control among hypertensive patients. Next slide, please. So they used the mixed methods, and for time saving, this looked at about 16,000 individuals who were in active care. We did interviews, pre and post longitudinal follow-ups, and then we looked at the acceptability, adoption, feasibility, and sustainability. Next slide, please. So this was published in the study, and we used the capability, opportunity, motivation model to be able to interview and follow up these individuals. Next slide. So what was found at the beginning is that those people who were living with HIV actually had almost 100% identification of disease, and then they were actually on treatment. You can see that the treatment cascade was actually 98%, as previously shared, because of the robust system of management of HIV. But contrary to that, in red you can see that actually, though individuals were diagnosed and screened for hypertension, those were screened, by the end of the follow-up, only about 5.1% were controlled for hypertension. And so we looked at the facilitators of hypertension screening, looked at the HEART's implementation protocol. This is where you look at health lifestyle, evidence-based treatments, and access to medicines. These people were given medicines, and then you use the team-based approach, and then the systems. Next slide. We reported that there was a great improvement after we applied this intervention. Next slide. So you can clearly see that after the interventions of COM-B, now the treatment of hypertension identification moved to 100%, and actually after 6 months of follow-up, 75% of people with hypertension were actually controlled. Next slide. So this actually illustrates that if you have systematic intervention, put in a protocol, and follow up patients on an existing platform like of non-communicable diseases, you can actually improve control of non-communicable diseases in those individuals by over 300%. Next slide. So this is actually, back one slide please. So these people were also followed up for 21 months. You could say that 6 months is a short time. And we actually found the same results. The control of blood pressure was much higher, and also the viral load maintenance was also still high at the same time, showing that you can actually integrate infectious and non-communicable disease together. Next slide. So really we learned that scaling up and integrating HIV and hypertension care is feasible, and then we actually have to look at getting drugs available to individuals or providing them at low cost, because that's usually a big problem. Task shifting becomes a very important aspect in caring for these individuals, and utilizing available resources and cascades of care can actually help to improve in this management. Next slide. So really, as I near the conclusion, it is important that we have the right policies to help adopt the best buys. I know Uganda is doing this very well, but as you can see, we are not doing very well on the health diets, which is the Achilles tendon. We also need to set up health systems. The art style, as I've showed you, worked very well. And I think we always need to think about the community, and the Ministry of Health is now using the CHOOSE to be able to improve care. Education is very important, but again, the key Achilles tendon is actually making data available, because even as we move into the AI-based medical care, it is based on data, and we are not capturing that data very well. Next slide, please. Of course, now I come back to our story. That young man you saw, who was actually on dialysis, was actually finally able to get a transplant in Mulago in 2023 December, is the one in blue there. And so once the government is committed to doing things, we can actually get the care that we need in the country. We have now done 12 transplants and accounting. So it's very important that whatever we do, we actually engage the government and get a buy-in. Next slide. So as I conclude, this is actually my last slide. So there are several challenges: unhealthy lifestyle, insufficient resources, policies that are hard to implement, and then limited awareness. So we really need to think hard on how to control. Our infrastructure is not ready to manage non-communicable diseases. So our best bet is actually going to be on prevention and control, health promotion, and ensuring that those who have disease get diagnosed early. And then we will need also a supportive policy development environment. Next slide. So as I conclude, I also want to invite you to attend the World Congress of Nephrology, which is going to be happening in Japan. I'm a member of the executive committee of the International Society of Nephrology, where I represent Africa. And so I would also like to invite you as we continue to fight non-communicable diseases. Thank you very much for giving me this opportunity.
Thank you so much, Dr. Kalyesubra, for such a wonderful presentation. As a keynote speech, he's actually not supposed to be taking questions, but he has been kind enough to agree to answer a few of your concerns and listen to your reflections as well. I'm also going to invite back the first presenter, so that they can both be able to take some questions and give us some answers to some of the things that we are intending to take. Yeah. So any questions from the audience? Kindly put up your hand and I'll deliver the microphone to you. Maybe I should be the one to ask the first question to the first presenter. When you're presenting, you said the adolescent girls and the young women were the ones giving you headache. And I was wondering to myself, if they are getting HIV, who is giving them the HIV? Because you're blaming them unilaterally. Yes, that will be my first question to you. And then to Dr. Kalyesubula, about the transplant program. How sustainable is this program going forward? Can we have some questions? Yes.
Thank you, Dr. Kalyesubula, for that excellent presentation. So the focus of this forum is to bring multiple stakeholders together and at the end come up with some action plans or recommendations to the ministry. I wanted to know from your work, which is quite extensive, what's the biggest headache you're facing, where you feel there's a low-hanging fruit that Ministry of Health and the government and the community could assist you in the work you've just presented. Because we really want to stick on things which are very practical and easy wins that will help us to the next step.
Thank you very much for the wonderful presentations. So I'm particularly interested in Professor Kalyesubula's presentation. We have done some work in the NCD space, but in the civil society angle. And in the urban centers, we know that, you know, we are always eating burgers and KFC chicken and all those kinds of very beautiful, nice foods. And it's very clear where the key drivers of NCDs are. The thing that is particularly confusing is in the rural areas. What exactly, because in the rural areas there is no KFC, there are no burgers, these people go and dig. What exactly is the driver of NCDs in the rural areas? That is still a very big, there's still a very big gap around there. Then also, coming from the civil society perspective, recently I've done a lot of work with the East African NCD Alliance, and recently we developed a regional strategy for the entire East African community. So coming from the civil society perspective, I'm curious to find out what can we do to support you such that we can help to drive awareness, we can help to drive maybe uptake and maybe whatever needs to be done such that we can ensure that the communities around us are able to know. And then is it possible for us to borrow some of the ideas we have from HIV? Usually when you meet any young person and you tell them, what's your status? They'll say, I'm negative. And it's well known that is an HIV way of creating awareness and getting people to know their status. Is there a way we can drive and ensure that maybe we have a campaign where we are talking about the awareness of your NCD status, and that could be on any one of the diseases, whether it's diabetes or something like that? I would love to hear your perspective on that. Thank you.
Thank you so much. Mine goes to Dr. Kalyesubula also. On policy enforcement, I know we have severally developed policies and very good ones. When projected, you just see flowers. everywhere. What we might have lacked is how to enforce and to implement these policies. What hindrances have you noted, and what have you suggested that could help us ensure that these policies are well enforced so that we have a healthy community? We are known to develop them, and most times other countries utilize what we do and they do it better. Thank you.
Thank you. My question goes to the first presenter. There is something that beats my understanding. I don't know, as Minister of Health, why can't we think of having a law to implicate people with HIV, those ones who know their status and they keep infecting the rest? We are fighting to eradicate, but there are those ones who do it intentionally to infect. Can't we have a law? Because that is a murder case. Can't we have a law to implicate and we enforce it?
Thank you very much. This goes to both of you. When you look at the national population census, it talked of life expectancy being higher in regions which are poor. How would you explain this in form of infectious disease and non-communicable diseases? Thank you.
Yes, I thank the two panelists, presenters. Mine goes to communicable diseases, the representative. I want Dr. Emma to see me clearly. Now, you talked about the infections of HIV, mainly, growing in the youth. I want to find out how often do you engage these youth? You talked also about multi-sectoral approach. As the Office of the Prime Minister, we are not seeing you. We only see you when it comes to health days, World TB Day, World HIV Day. How often are you engaging these ministries? For instance, when you look at these youth, that is Ministry of Education, that is Ministry of Trade, where we get the young adults who engage in the businesses. So I want it to come out clearly, because we only see you in those particular days, and yet the numbers are rising. Thank you.
Thank you so much, our presenters. It has been a good presentation, and I think we have learned a lot. So we have a lot of myth regarding our NCDs. Last time I was looking at social media, and people were discussing the death of a lecturer who had taken 15 years without taking sugar, without taking alcohol, and he died of diabetes. So people were like, this one had taken 15 years. Now, what's the difference between him and me, who is taking? So how are we dealing with that? Then 50% of undiagnosed DM seems high. What are we doing to bring down that number? The other thing is, as a nephrologist and other NCD advocates, do you work with your NBS to control most of these things that are entering in our country, like tobacco? It is very harmful. It's not as like the level, those substances which are entering Uganda are totally different from the ones which are in China. Have you tried working with UNBS to regulate that? Then on HR, you talked of 14 kidney specialists in the country. How many are employed by our good government? Thank you.
Thank you for the questions. think let me stand here. I just have one more question for Dr. Kalisula about the hypertension. I think slightly more than 20% of the population has hypertension, and I think only 1 in every 5 is on treatment for hypertension. Now, how available are the medicines, and are we sure that people with hypertension, especially in the villages, adhere to these treatments, and when they need a refill, is it available and accessible to them? So I think I'm going to allow you to answer those questions, and then we can move forward. Thank you.
Thank you all for your questions. I will briefly respond to all. The first question came from our moderator. Yes, the prevalence of HIV among adolescent girls and young women is quite high. But the question is, who is affecting our young ladies? And I think the answer is very simple, especially in an African setting where we believe that it's only a man who can have sex with a woman. So infections are coming from men, older men who have got the money to confuse our young girls, and poverty is driving them towards cross-generational sex. But also culturally, our girls are not empowered to say no to advances. They're also not empowered to go out and ask for preventive measures like PrEP. They feel ashamed, they feel shy. So the girl goes in and gets it from the older person who just wants to use her, who just wants to satisfy his desire. There's also the issue of lack of education. If you take your children, if you empower a girl by educating her in school, taking her to school, they are less likely, they are more empowered to say no. They are more empowered to read, to know information about prevention. But girls who have not gone to school stand higher risks of getting HIV. And that's why we're encouraging people, let's concentrate on taking our girls to school. Let us empower girls, take them to school, but also ensure that they are kept in school. They shouldn't be dropping out. Someone raised the issue of, can we have a law to implicate people who infect others intentionally? It's very hard to know that someone intentionally infected the other person, because we believe there must be a consensus between the two people. And it's very hard to know that so-and-so did not declare his status. How do you know that I did not tell someone that I'm HIV positive? Because we have heard of stories whereby the other partner says he declared his status, but the other person said for her she doesn't mind. Let them just go on, and whatever happens, God will know. So it's something that we cannot just bring. I am not aware of any country which criminalizes that kind of interaction. And I don't think Uganda is going to be #1 for now. Yeah. The life expectancy is higher among the poor people than the rich countries. And I think the reverse is also true. Yeah? We see the more our country becomes better in terms of economic status, the life expectancy actually goes higher. When you look at the world all over, a first world country, the life expectancy is higher. But when it comes to poor countries like African countries, life expectancy is low. And what is killing our people? The infections, undetected non-communicable diseases, and so on. Weak systems, actually, because of poor economic status, reduce life expectancy. So we know as economic status increases, life expectancy also goes higher. I think my good friend Dr. Linda from OPM is asking me how often do we engage the OPM office. Yes. Linda, it shouldn't be you asking such a question, because you very well know how often we meet. Beyond World TB Day, beyond HIV AIDS Day, we meet. We have quarterly performance review meetings. involving different ministries actually, because we have a multi-sectoral accountability framework for diseases like TB. And every quarter we meet and people make accountability of what happened to their ministries. But we also have quarterly meetings, like coordination meetings. For example, we have National Coordination Committee of the TB and other diseases, and we invite your people. But we also involve in a number of activities. For example, we have community-related activities like what we call community awareness, screening and testing. Your officers are always part of us. And I think recently we got a gentleman called Ngobi, who is very active in our activities. So we meet very often. You may not come as an individual, but your colleagues always attend. Thank you. Can I pass on?
Lucky you, Dr. Emma. You have finished. So I see there are a lot of questions, which is also very interesting. The first one is about the sustainability of the kidney transplant program. The government is initially funding the kidney transplants, but we believe that soon individuals will be paying or contributing some money to the transplant program, and that will probably ensure its sustainability. We estimate that the transplant will cost about 50 million, but currently people are paying 150 million or 200 to get it outside of Uganda. So this would be a quarter of what is expected, and I think once that gets into motion, the numbers would increase and the cost might continue to come down. Then the other question was from Dr. Lukoma. He's asking the takeaways on what needs to be done, what is that big issue that needs to be addressed for non-communicable diseases. I think the best bang for the buck is going to come from screening, and I'm happy to see my boss, Dr. Mutunji, here. So 90% of people with kidney disease don't know they have it. About 60% for hypertension. We talked about 45% for diabetes mellitus. So the biggest bang for the buck is going to be screening. But of course, screening can have its negative effects if the system is not ready to receive and manage these individuals. Then the next step would be having proper diagnostics to ensure that those who are screened, they really have the disease, and ultimately referrals to where they can get care. One of the easiest ways I've showed you is that almost all the non-communicable diseases can go to the community by use of community health workers, and I think that needs to be reinforced. Then the third question, I didn't get the name, but it's about non-communicable diseases, the civil society, how people in town are actually having these big bad lifestyles, and they are driving the epidemic. So he's asking what is happening really in the rural areas. People are not eating these burgers, but they are still having these complications. You saw that one of the leading issues is that people are not having enough fruits. That's one. The other issue is the nature in which our plates are arranged. If you grew up in the village, you know that we are mainly carbohydrate individuals and we get very little protein. So that high carbohydrate, of course, drives the metabolic side. I didn't express here, but today we talk about the cardiovascular, kidney, and metabolic syndrome, which largely comes from the diet. Once you take in a lot of carbohydrates, they deposit the fat on the wrong parts, and then that actually begins to turn on the cascade of non-communicable diseases. But also the salt intake. A lot of people take a lot of salt. It's recommended that we should take less than 5 grams in 24 hours, but a survey showed that the majority of individuals, urban and rural, take about 6 to 7 grams of salt per day. So that's another big driver. And then, of course, you say these people go digging, they do what, that protects them, and I think exercise was not a very big issue, but those other factors. And then we also have factors that come, genetics, and also factors that come in utero. In fact, if you see most of us, except people like Dr. Mutunji who are tall, the majority of us are short people, and our children are much taller than us. Maybe because of the way we grew up. We used to carry big jerrycans, we used to eat these carbohydrates. So that predisposition carries on that non-communicable diseases come earlier. Our non-communicable disease average is about 40 to 50 years, whereas in developed countries it's 60 years. You can reflect on that. If you have children, you realize that if you've given them the life, they are taller than you. So we think some of those things we've not studied come in. Then he talked about the NCD regional strategy and how we hope to tap into that. I think the best way is mediated by the Ministry of Health. Our focal people from the non-communicable disease department. Dr. Mutunji is here. I think he puts us together. He brings all the stakeholders in non-communicable diseases together. This person asked a lot of questions. He asked, what can we learn from HIV? One of the things I showed you is that that was actually an offshoot of the HIV program. We don't need to reinvent the wheel, but you need good systems. You need to be able to manage. You need to manage the cascade of drugs. You need to manage the referrals, and you need to improve the awareness, just like Dr. Emma said. So that, I think that's what we are learning from HIV. But also remember, HIV was very well funded. You know what happened when you said pulled the plug. So I think the government needs to begin funding some of these programs. The fourth question is on policies and their enforcement. We have very good policies, but how come they are not enforced? What are some of the key hindrances we've seen, and what can we do to make it better? The major challenge with non-communicable diseases is that we receive funding from different sectors, but if you follow the media, you just saw that America awarded us 1.7 trillion shillings. So I hope that the Ministry of Health will now have no excuse, because we used to rely on other sector players, but now the ball is in their court. So I hope Ugandans can rise up and demand for services for health. And I hope that as those contracts are being signed, now the government will definitely have better capacity to deliver without middlemen. So I think that's going to be very critical. But in the past, NGOs have been actually working, sometimes getting together has been difficult, because if you say it comes, it says for us we want to fund HIV. And if you have non-communicable diseases, there's nothing you can do. Now the man has gone to the what? To the government. So probably they will have their priorities. Hopefully they will base it off the evidence. Okay? Then, of course, civil society support. The other one is the national life expectancy, why it is poor. Dr. Emma answered that. I think the poor people don't live longer. It's not true. Everywhere in the world, poverty kills you. In fact, we say, if you are broke, you are just one admission away from death. Even if you get admitted in Mulago, which you think is a free hospital, once the bills begin to pile up, they tell you to go and buy the dialysis catheter, and you can't buy it, you die. So poverty kills. So that is not debatable. When you are poor, you die more. No question about that. Yeah. So the myths on NCDs, how come those people who live in the villages who are smaller are actually now getting non-communicable diseases? How do we explain that? I hinted on it earlier, but we now have some evidence coming out. People have looked at diabetes. Dr. Chibirige, working with MRC, actually they've gone and characterized the type of diabetes we get. It happens that even before we are born, when we are still growing, some of our organs don't grow very well. Diabetes comes from an organ called the pancreas, which actually produces insulin. So if people are malnourished during pregnancy and after when they are born, their pancreas has actually become sicker. And that's what actually led to the birth of now we call type 5 diabetes. So we have peculiar risk factors. Even when we are smaller, those things keep driving the diseases. We believe it might be a similar story for kidney disease. For instance, people who are born prematurely, those who don't get enough nephrons, they actually also get predisposed much earlier. And I think it happens the same way in hypertension. For cancers, we probably have some genetics that are driving the disease. For kidney disease, we also have genetics like the ApoA1. So those peculiarities come in. But again, people in the village environment, as I told you, they are not living a very good life. Okay, they go and dig, but then their diets, they are mixed up. They put a lot of carbohydrate. They eat meat on Christmas, so they lack the proteins. So all those things actually come in. And when they get the fruits, you know where they come. You people in Kampala buy them, and then they get the fudge. So they actually don't get the benefit of the work they do. I think those are some of the things that drive this. Then he talked about UNBS role in controlling some of these things that come to our country, like the tobacco control. I think the ministry has done a very good job here. They've developed a policy on tobacco. They went to the growing, up to that level, labeling. And if you saw our statistics, actually the influence from tobacco for non-communicable diseases is very, very little because of, I think largely because of what the government has done, but also because we are non-characteristically smokers. I think what is a bigger problem is actually, which has now come third, is the environment. This smoke you keep getting, the Lung Institute, Dr. Bruce Chirenga, Professor Bruce Chirenga has unveiled. If you came in the morning and you looked at the environment in Kampala, the air is polluted. People cook under kitchens which are not open. So biomass is now actually a bigger problem than actually the smoking. But granted, we still need to control smoking. For you who are young, you need to control these other things which are modern ways of smoking, like is it shisha? Shisha. Now that's where you need to look as parents. But yes, the government is doing a good role. The HR, we are 14 nephrologists. How many are employed by government? It's 5 out of the 14. And of course, we don't yet have a training program for nephrologists. We depend on external funding. I'm happy that there's a fellowship here. If you gave us one nephrology training per year, we'd be very happy. Kofih, if you gave us also a nephrologist to be trained per year, we train them for only 2 years. So that would be very welcome. Then the other question was around hypertension. These questions are too many, by the way. I'm sorry if I'm rushing through them, but the 10 questions to a keynote speaker. Chair, you did not protect me very much. You would have said, ask him 3. But anyway, nevertheless, they came through. So hypertension, more than in 20%, 1 in 4 people have it. Are the medicines available? When people, if we diagnose them, can they get this? If they get, is there a refill? Well, one of the challenges that we have is that these medicines are not readily available. I'm happy to see Dr. Mtunji. They're actually working on this very, very much. They have, and I might mistake in the words, but the clinics actually have to request for the drugs from the national medical stores. So depending on how many people have been diagnosed, you can actually order these drugs. Of course, sometimes they run out, and what people have done together is create groups. They create groups where they contribute, and they are able to buy pooled medicines, but yet the availability of drugs is not so common. But we fought hard to get some of these drugs on the essential medical list. Once they get on the essential medical list, then the government is obliged to actually supply these medicines. I think that was the last question, and I think I've managed to answer.
Thank you so much, Professor Kalisura. Please, let's give them another round of applause. And I would like to request all of us to come and have a picture with our keynote speaker so that we can go off for a breakfast and then come back for the next session. Kindly come forward. We have a photo, and then we can move on. Yeah, you come. There's a camera. Let's move a bit faster. Sorry. Good day. Our Commissioner of Non-Communicable Diseases is humbly requesting that we give him 10 minutes so that he can address us because he's going to go away. Commissioner, you're welcome to the podium. No, he's going.
Good morning, colleagues. Apologies if I have delayed your breakfast, but you will realize that some of those breakfasts are the ones causing NCDs. Yes, you will see when you go there, you will see what you will find on the menu. The carbohydrates our professor was talking about is most likely what you are finding. I'm waiting for my presentation. Just give me 10 minutes. But I want to appreciate Dr. Karyesubura. He answered the questions very well. And importantly, he didn't blame the government. Because I've always told them that we're going to do this together. Advise us, let's handle this together, other than always blaming the government. So will you be controlling the slides, or I have something to control the slides? Oh, next, okay. So we are going to talk about the priorities. First, maybe a little bit about the burden, but mainly it's the priorities and what we can do together. So let's go to the next slide. So the NCDs are no longer diseases of the wealthy, and I was happy that you were already mentioning that there are NCDs in the village. But they have come to a major development challenge, and NCDs account for an increasing proportion of morbidity and mortality. Probably Dr. Karyesubura mentioned that. It's a silent epidemic now. The high prevalence of undiagnosed hypertension, undiagnosed diabetes mellitus is just a critical issue. And many cases, especially of cancer, but not only cancer, even kidney diseases, are only detected at a late stage, We have also issue of mental health and substance abuse on the rise. And really the costly lifelong treatment burden strains both the households. Dr. Kariasovra said that if you are poor, you are one admission away from death. But because these NCDs, once you are put on treatment, most likely you are going to be on treatment for life. They are expensive. They will make you poor. They will make the families poor, but also affect our budget. And that's why we are not getting many donors. You see, when you treat malaria, you have 5 days at most and the malaria is gone. But when you treat hypertension, what is the end game? If somebody gets hypertension at 35, he will going to live for more 30 or so years on the drugs. So that's why our imperative is to shift from curative to prevention, because treating these complications is not sustainable. The kidney diseases, if you go to Churura and you see the number of patients that are on dialysis, it's unfortunate. They are making people poor. I was talking to the director that they go and sell their biranja to come and keep on dialysis. This dialysis is not the final solution, isn't it? Dialysis is temporary. You are just there until a definitive solution is found. And sometimes that definitive solution is not found. But you have already sold chibanja, your children have left school. So really, unless we emphasize prevention, we are not doing well. Next. So the major NCDs, which cause 80% of the death globally, are those ones. Diabetes, 1.6 million, respiratory diseases, 3.8, cancers, 9 million, CVD, 17.9 million, and then the others, 8.2 million. So you can see that cardiovascular diseases alone, that group of diseases, cause up to 44% of non-communicable diseases. And what is down there are the shared risk factors. Shared risk factors and healthy eating that we are all prone to, and we are going to at the break. You watch what you are going to take. Tobacco use, physical inactivity for the last 3 days. You reflect how much physical activity you did the last 3 days. Yes, then excess alcohol, but also environmental pollution now has come up as a very big risk factor. Next. So the policy and guiding framework, you know, we have a multi-sector strategic plan. We have even a multi-sector committee that is supposed to be chaired by the Prime Minister's office, my colleague. They have not been very enthusiastic about it. But we have actually, because we know that the risk factors are outside the health sector, if we are to emphasize prevention, we must have those sectors. Tobacco consumption doesn't fall in the health sector. Alcohol consumption, physical inactivity, unhealthy eating are all in other sectors. So we must work together to handle those risk factors. So we have a multi-sector strategic plan. I think it is getting expired, but we are renewing it. But we also have some legislations. We have the Tobacco Control Act that is trying to make smoke-free environment so that those who don't smoke are not exposed to tobacco smoke. The implementation, as I've heard some of you say, is an issue, but at least the law is there. We have the Mental Health Act, but we also have ministerial directives. For example, to integrate NCDs into all primary health care pathways. But we have also established a national task force on a sickle cell disease, which is one of our major NCDs here. Next. So I was asked to emphasize things that we can do with partners, including Kofih. These are our strategic objectives or priorities. how do we create awareness, and how do we prevent the risk factors. So sensitizing the MDAs and the communities about risk factors is very, very important. We are doing some interventions here. You know, we have the National Day of Physical Activity. We commemorate those national days or international days. World Diabetes Day, World Heart Day, World Kidney Day. This year you didn't invite me. I don't know whether you commemorated World Kidney Day. But we do that to sensitize the communities and remind them of these factors and how best we can prevent them. About the risk factors, especially in the community, we may assume that people know, but they don't know, including doctors. You check what you put on your plates when there is a buffet. The concept of buffet was to give you an option. That you can choose 2 or 3 what you want. But people think it is an obligation to take on anything. And even the last 2 days I was seeing it in this meeting. You put white rice, you put brown rice, you put Irish potatoes, you put sweet potatoes, you put matoke, posho. I've been watching here. So imagine what you are eating. Rice, posho, matoke, yams, and there is also pumpkin, and there is gonja. Even macarons, all those who are being put on your plate. Today you will know it. But also the portion, and I'm happy I'm hearing that, because when I gave this talk to some doctors, there is a senior doctor who is the chair board of Kabale Regional Hospital. He said now whenever he's serving food, he remembers what I said. Because the portion is also important. You fill the plate and you want also to push with a rod or a spoon to see where to put the sauce. So what are you? This happens in the villages also, because you people, you think in the villages there are no risk factors, but this also happens there. There is chapati and chukomando in those trading centers. They now even take chips in those trading centers. So these factors have gone up to the villages. So today when you are serving food, consider the portion, but also how much carbohydrates are you taking. I don't mind if you fill the plate with the vegetables. But if you fill it with those carbohydrates, now wonder. Another epidemic that is happening is fruits. Because we have saying you take a lot of fruits and vegetables, people are taking platters of fruits. For lunch, for breakfast. Fruits have sugars. So you also need to consider the portion. I've seen in some of our restaurants now, they serve big plates of fruits as a healthy alternative. But it's too much. That plate of sugary fruits. And people don't know. And I want you to support me to make people know. This is where we can pattern a crease, isn't it? This is where we can pattern. Next. Next slide. The other, yes, the one before. So when we come from prevention, when you come from the risk factors, the diet, the physical activity, the tobacco, the alcohol, you know how much alcohol we take. We don't win in football, we don't win elsewhere, but we win in alcohol consumption. Do you know we are number 1 in Africa or 2? 1? This year we are number 2. You see, we are doing well. From number 1 to number 2. What about football? Are we qualifying for World Cup? We are not. If we are watching. So the way we consume alcohol. So now the next priority is here is screening. Patterners. Let's pattern and we screen all Ugandans for hypertension and diabetes. Because what Dr. Karyesura is suffering from, the kidney complications, mostly they are from those two. from diabetes and hypertension. Uncontrolled diabetes and controlled hypertension will give you kidney failure and the chronic kidney disease. They will give you stroke, they will give you heart failure and many things. And many people don't know, including doctors and some of you who are here. You may be having hypertension, you may be having diabetes and you don't know. This is where we can partner with the civil society, with the other partners. Let's screen everybody. They were asking me whether it is ethical to screen somebody when you don't have medicine. But what is better? Not to know and you die there, or at least you know. At least you should know you can sell your chicken and look for treatment, but also there are other ways of controlling hypertension and diabetes without medication, non-pharmacological ways are always available. So when they asked for that ethical question, I said it doesn't have to be drugs. If they catch you early with diabetes, you can change your lifestyle and the diabetes might go. Even hypertension can go. But also, if there are many people, you put the government on pressure, it will find drugs, other than not knowing. So for me, I encourage universal screening. Let's screen. People will make noise and the drugs will be found. Because we lose those opportunities. But now we have directed that everybody who comes to our health facilities must be screened, irrespective of why you have come to the health facility. So if you have come with malaria, or you are pregnant, or you have anything else, you have an injury, you should be screened for a minimum hypertension and diabetes. But this is not enough. We need to go to the communities, the outreaches, and do screening. So what partners can help? Let's enable, let's build capacity for screening, because some of our health facilities may not have the necessary equipment. Like the blood pressure cuffs, the blood pressure machines. The glucometers are there, but they don't have the glucose sticks to do. So that is where we can, those are small things that can make a big difference. So Kofih, if you are making a budget, you can say we shall support government health facilities to have glucometers, to have BP machines, but also to supply the necessary logistics, but also the data. The data, and we are working on that. The tools have been approved, and they are going to be part of our HMIS. Next slide. Then the other cancer screening, I think I'm not qualified. I'm sure Jasso and others must have talked about cancer screening. The current state of Uganda Cancer Institute, I think 80% of their clients are in stage 3 and stage 4. And I was telling my colleagues, I don't envy them. I don't want to be an oncologist who are seeing people in stage 4 and they are definitely going to die the next year or 2. We need to screen early. So we need outreaches. We need more resources in the communities, in public health care facilities. And when I say this, sometimes my friends at Uganda Cancer Institute don't like me. We put less money in Uganda Cancer Institute, but more money in primary health care facilities so that we screen and send these patients to you early when they're in stage 1 and 2, when they are likely to be cured. But when we keep on funding too much the Uganda Cancer Institute to acquire all those technologies and we forget to empower the primary health care facilities, I think we are doing a disservice. So, screening for cancer, Kofih has helped us, and PEPFAR, when PEPFAR accepted to use some resources to screen cancer of the cervix, we moved from 10% of the eligible people to 23%. Our target is 50%. At least we moved from 10% to 23%. We want to go to 50%, but even 50% is not enough. And other cancers that can be screened. Breast cancer and prostate cancer. There are cancers that may not be screened, but there are those ones we can screen, and we need to emphasize screening. I think in the southwestern region, GIT malignancies are now common. We need also to develop screening methods, either occult fecal blood or something. We need to screen people early than what we are seeing now. So for us, we are trying to screen at primary health care level, at least for cervical, breast, and prostate. And we call our partners to support us. We are grateful to Kofih. It has supported us in cervical cancer screening. I've requested them to add breast, but let's also think about prostate cancer screening. HPV vaccination for girls between 10 and 14 years is doing well, by the way. We were doing poorly with the second dose, but when they said that the first dose is adequate, we are doing well, and we need to be supported to continue the trend. Next. Sickle cell disease is another big issue. It's actually a forgotten epidemic. In some districts, I don't know whether I quoted some figures there, but the prevalence of the gene is up to 13%. Is this 13 or 1.3? I think it's 1.3% of all Ugandans have a sickle cell trait. But in some districts, it's up to 25%. So imagine if 25% of people have a sickle cell trait, and you know how we like marrying nearby. We like marrying in our districts. So it's likely that you are going to transmit that gene. You marry your neighbors, because those are the ones you interact at the church, at school. There are some areas where the gene is the prevalence of the gene is so low, like in Kabara and where. And I don't want to repeat the mistake. That's why they said that I advised the Teso people to marry from Kabare. I saw it in the papers. But I was only saying that in some areas, yes, that's what they quoted. I said that the commissioner advised the Bateso to marry Bachiga. It was the headline. But that's not what I was saying. I was saying that some areas, the prevalence is low, but in some areas it's so high. In Teso, it is about 20%. So you are likely to get. So we need to emphasize screening before marriage. And there are other strategies we are trying to develop to screen, for example, in schools, and we put it in your child health card, that you are a sickle cell carrier or you are a sickler, so that you grow up knowing. And when it is time to look for a partner, you say, but do you know I'm a carrier? If you are a carrier, then maybe that's not. So it's a big challenge. We are now doing newborn screening, because also once they are put on treatment early, they survive better and they can live up to their potential. So you can support us in newborn screening and those early interventions. At least the policies are there. We have now even the sickle cell management guidelines. Next slide. So mental health, support us in capacity building, in training our health workers at the primary health care level to be able to diagnose and manage uncomplicated mental health conditions before we refer them to Murago. We are trying to build alcohol and drug addiction treatment units at all referral facilities. That's where you can support us, and to ensure that our health center 3s are able to manage, to integrate mental health into NCDs. Next. So the challenge and then the opportunity for change, high cost of care, we shift to primary prevention. It's cheaper and more sustainable. Late diagnosis, we integrate screening in our routine care and even outreaches so that we diagnose early. Serial programs, we are now integrating. issues with the data gaps. We are digitalizing, and I think we shall soon be there. Workforce shortage, task shifting, and skilling the community health workers. And the CHOOS here come handy. I mentioned that we are training CHOOS who are able to do some good work in the communities. And we have trained in about 35 districts out of 140 partners who can support us in training in other districts. You are welcome. Next. I thank you very much. I'm sorry I'm in between you and your breakfast, but I have another engagement at 11. Most of the questions were actually answered by Dr. ChallengesHEALTH, but if there are some, they can be entertained before we go for breakfast. I thank you.
Maybe you can stay here. All right. All right. Can we have some questions for our commissioner?
Thank you so much, Commissioner, for this nice presentation. I just want to give reassurance that in the area of cancer, where you said you're seeing some challenges in terms of taking services to the primary care facilities, I want to reassure you that you have seen from the Kofih model that all our interventions, so long as you channel it through the community department of the Uganda Cancer Institute, we are able to reach the communities, we are able to reach the primary care facilities. So just calling upon the Minister of Health, any resource you see somewhere where you feel we can use that to take cancer control services to all the health facilities in Uganda, we are willing to support that. But you need to enter through the community section of the Uganda Cancer Institute. You enter through, when you look at the oncologists, the one you're speaking about, it may not be their priorities, as you know very well. But we are working towards that. Any resource we find, you look at community first, up to village health team level and choose. Yeah, thank you so much.
Thank you so much. What is the digital health integration in?
Thank you so much. My question is regarding HPV vaccination. I noted that you said we have a good uptake right now that we are considering single-dose vaccine. Over time, I've been questioned about the possibility of availing HPV vaccine to non-children, for example, for young women who have been tested to be maybe negative. Is it possible to avail this service, even if it's at a cost, to such ladies? Thank you.
Any more questions? It's not easy to meet the commissioner, so we take the opportunity when he is here.
Thank you so much, Dr. Gerard, for the wonderful presentation. Mine was on the issue of looking at the chronic lung diseases. It's one of the major NCDs that we have around, and when you look around, it's almost affecting a significant number of our population. But the interventions, even at the clinical care level, is completely almost not there. If you go to regional referral hospitals, they will tell you they have a number of patients, but when you're going to find out where they are managed and how the data is collected, it's a challenge. And I think the Ministry of Health and the NCD department should start looking out for maybe partners to support this. And Uganda NCD Alliance has started the journey, and we want to call it to support us and look for other funders to support us in this same way. Then, of course, the other one I also want to emphasize on the issue of data collection, then maybe use the data and generate reports. Yesterday we were going through the, people were making presentation and talking about how they are receiving it, data in the HIS2 and the other one that we get through the HMIS. I realized that actually the data that you get at the Ministry of Health, you just receive data just for the purpose of, you get what you get, you compile and report. And then you don't even give feedback to the people who have given you this data. So it's not used at the facility level. And many times we do not get adequate data to be able to inform and decision making. And no wonder many decisions, especially in NCDs, and maybe many directives that have given out, you go back to the facility level and things are the way they are from January to December, and then you go to another year, and then things are not working. So I'm requesting that as you generate and get this data and analyze it and get the reports, tease out specific areas and give feedback so that people can locally use data and know what it means to them. Not just collecting data and then give it to Ministry of Health, then you analyze at your level and then you report and then people do not know. Their work is just to keep data and, to pick data and then give to you. So it is incomplete, or sometimes it's maybe the quality also has another issue. So my humble request is that let's find a way of localizing the reports that we get, that we analyze at the Ministry of Health level, so that we can fight and see this. Like I said, I want to emphasize this. The statistics that Dr. Gerard has presented and all that we read and see is just a small thing compared to the problem. Because I always emphasize that behind these statistics, there are people, me and you. And if we do a random sample here and ask anybody here who is not connected to an NCD, you find all of us have either a relative or ourselves. And before even look out to the people to come and support us, or to go to advocate to other people, let's begin with ourselves. Professor Kaliesubra, and I also tell some of your senior colleagues, your colleagues at your level, that when you're treating these big people up there, if he sits before you, tell them, because they're the ones who hold the decisions. They come, they're living with hypertension, they're living with diabetes, and then they keep quiet and then they don't want to give us funds. But they are the very people who consume these services, and they're the ones who take decisions. So every time you're treating them, at least whisper into his ears and say, but we need the resources for prevention. Thank you.
Dr. Mtunji, thank you so much for that excellent presentation. I have a concern with the death certificates. And I think the people who are collecting cause of death, that team is very actively ensuring that hospitals are recording. But my concern is when people have multiple comorbidities. I think that, to me, it seems like the pathologist may list all the diseases that are relevant, but when it comes to that short death certificate, the thing that goes to NERA, it's like somebody else is just deciding which disease to record, which is, I think, a big disservice to the final statistics, the vital statistics that we're having in Uganda. I think there should be somewhere where there should be some control over when the pathologist has determined that this is the cause of death and he has listed 3 or 4 diagnoses, that information needs to be passed on. Because if supposing somebody had kidney disease, sepsis, and HIV, and those are listed on the certificate, in the post-mortem report, when it goes to the cause of death and that process that goes to NERA, you may find at the end of the day they are just listing sepsis. Some of these things are political decisions. Some may be that the family doesn't want to be embarrassed, but I believe it is affecting the statistics and what you're eventually reporting as how many people are dying of X, Y, and Z disease.
Thank you very much for your comments and questions. Just so I know the cancer community department is doing its best. We work together. But please understand us also if we say most of the investments should go to the primary health care than the high tech. Integration in digital health is just meaning that we are putting many indicators into one system, one app, so that we don't have NCDs alone, HIV data alone, TB data alone. So we are integrating it in one system. I think that's what it means. And the PS is very serious now on electronic medical records. I think she said she's no longer looking money for printing paper registers and what. So that's the way to go. Young women, you get the natural protection. So it will be a wastage of vaccine again, vaccinating you. You get me? It may not be very useful. It may not be useless as I can say, but it's not very useful. It's not a good public health intervention once you have been sexually exposed. That's the data we are getting. Once you are sexually exposed, the HPV vaccination may not be useful. If you don't have HPV infection, it means your immunity has cleared it and you got the natural protection. It's the problem with the smaller percentage who get persistent HPV infection that will cause issues later in life. And once you already have persistent HPV infection, the vaccine will not help you. So that is the science. Actually, you should be advocating for young boys who have not been exposed to it, because women eventually get it from men, isn't it? So we should even be protecting the young boys, but because of resource constraints, it is not cost effective because of the little resources we have. But developed countries who have money are also vaccinating boys, so that the boys are also protected, and HPV can cause cancer in their reproductive system as well, cancer of the penis. So for women who have been sexually exposed, it's neglected. I agree with you, Chris. But the Makerere Lung Institute, we are working together with Makerere Lung Institute to make a difference. They are building capacity, starting with regional referral hospitals, but also some primary healthcare facilities. Spirometry and all that are not easy things to do, but we are working with them, and probably something will be done. The data at the facility level, you partners help us. We have always told them that you are not collecting data to take to Ministry of Health. The analysis should be at the point of collection, and the decision should be made there. But I agree with the recommendation that with us also, we should also give them feedback. And sometimes we do, but I think it shouldn't wait to go to the national level. Where the data is collected, it should be analyzed, and the decision is made at that level, and our partners can help in that. This certificate, that was a difficult question, but I think it's a recommendation that we can recommend to our partners. But again, they cannot put more than 4 reasons of death. They normally put 1 and the predisposing. Otherwise, if there is sepsis, there is kidney failure, there is whatever, somebody who is filling that form may not put 5. I don't know what you recommend. Should we, because currently there are 2, the immediate one and the predisposing one. I don't know whether you are saying that we should create space for 5 and whether that will help in the end. But it is something that we can discuss during the break tea. I thank you very much, and I will not be able to stay here for long. I have some other commitments, but also at the ministry we have end of year staff party. And only those with the Ministry of Health identity card are invited. Thank you.
Thank you so much. Another round of applause for our commissioner. I really appreciate. So I've been informed that the Director General of Health Services will join us virtually this afternoon to close the event. But right now, I think let's break off for our breakfast. Kindly watch the portions as we've been cautioned, so that we don't put ourselves at risk of the very things that we are trying to fight. Thank you. See you after the break time.
strengthening is an urgent ask to all of us. So therefore, we must take this as a priority.
So I just wanted to, to emphasize the fact that a lot of the challenges that we talk about are everywhere. I've never worked anywhere that didn't struggle to bring quality emergency care to its most vulnerable patients. So I think that remembering that it is actually a global challenge, we can maybe start to think about what some of the tools are that we can draw on across the board.
So as government agencies, please, let's pass the act or fight for the act. Let's fund for establishment of coordination centers for ambulances. And then let's have the EMS cadre that is specific to provide emergency care across the country. This is not a dream. It is a project plan. Our mission transcends policy. It is moral commitment to safeguard our people. Let's be architects of that system. Let's build with urgency, scale with purpose, and resource with determination. Esteemed development partners, distinguished guests, colleagues, ladies and gentlemen, good morning. We're here today to confront a simple, stark truth. In Uganda, whether the person lives or dies during a medical emergency still depends too much on chance. Our mission is to replace chance with a system, a resilient national emergency medical services that leaves no one behind. Our homegrown Uganda trauma assessment and treatment algorithm, TUTATA, is a proof of what is possible. Developed here, tested here, and it is dramatically reduced trauma mortality.
TUTATA also aligns with national EMS priorities. It supports the implementation of the EMS Policy 2023, which emphasizes the standardization of emergency care.
So we implemented the first phase of the EMS project for a period of 6 years, and the target area was Ministry of Health, Kampala, then we were in Bukoma, Simbi, and Masaka. Then the goal was to contribute to achieving the universal health coverage through improving health conditions of vulnerable communities. We set up a surgical ward at Butenga Health Center 4. We built a fully fledged operation theater. We fenced the entire facility of Butenga Health Center 4 of about 15 acres.
We need money so that we can achieve all this. And the only sustainable source of funding is from government. We are also looking at partner financing. Kofih has already done a lot through the KGA project like this one. It gave us $30,000, and this is what has made us come to the point where we are.
National EMS strengthening is an urgent ask to all of us. So therefore, we must take this as a priority.
So I just wanted to, to emphasize the fact that a lot of the challenges that we talk about are everywhere. I've never worked anywhere that didn't struggle to bring quality emergency care to its most vulnerable patients. So I think that remembering that it is actually a global challenge, we can maybe start to think about what some of the tools are that we can draw on across the board.
So as government agencies, please, let's pass the act or fight for the act. Let's fund for establishment of coordination centers for ambulances. And then let's have the EMS cadre that is specific to provide emergency care across the country.
This is not a dream. It is a project plan. Our mission transcends policy. It is moral commitment to safeguard our people. Let's be architects of that system. Let's build with urgency, scale with purpose, and resource with determination. Esteemed development partners, distinguished guests, colleagues, ladies and gentlemen, good morning. We're here today to confront a simple, stark truth. In Uganda, whether the person lives or dies during a medical emergency still depends too much on chance. Our mission is to replace chance with a system, a resilient national emergency medical services that leaves no one behind. Our homegrown Uganda trauma assessment and treatment algorithm, TUTATA, is a proof of what is possible. Developed here, tested here, and it is dramatically reduced trauma mortality.
TUTATA also aligns with national EMS priorities. It supports the implementation of the EMS Policy 2023, which emphasizes the standardization of emergency care.
So we implemented the first phase of the EMS project for a period of 6 years. And the target area was Ministry of Health, Kampala, then we were in Bukoma, Simbi, and Masaka. Then the goal was to contribute to achieving the universal health coverage through improving health conditions of vulnerable communities. We set up a surgical ward at Butenga Health Center 4. We built a fully fledged operation theater. We fenced the entire facility of Butenga Health Center 4 of about 15 acres.
We need money so that we can achieve all this. And the only sustainable source of funding is from government. We are also looking at partner financing. Kofih has already done a lot through the KGA project like this one. It gave us $30,000, and this is what has made us come to the point where we are.
National EMS strengthening is an urgent ask to all of us. So therefore, we must take this as a priority.
So I just wanted to, to emphasize the fact that a lot of the challenges that we talk about are everywhere. I've never worked anywhere that didn't struggle to bring quality emergency care to its most vulnerable patients. So I think that remembering that it is actually a global challenge, we can maybe start to think about what some of the tools are that we can draw on across the board.
So as government agencies, please, let's pass the act or fight for the act. Let's fund for establishment of coordination centers for ambulances. And then let's have the EMS cadre that is specific to provide emergency care across the country.
This is not a dream. It is a project plan. Our mission transcends policy. It is moral commitment to safeguard our people. Let's be architects of that system. Let's build with urgency, scale with purpose, and resource with determination. Esteemed development partners, distinguished guests, colleagues, ladies and gentlemen, good morning. We're here today to confront a simple, stark truth. In Uganda, whether the person lives or dies during a medical emergency still depends too much on chance. Our mission is to replace chance with a system, a resilient national emergency medical services that leaves no one behind. Our homegrown Uganda trauma assessment and treatment algorithm, TUTATA, is a proof of what is possible. Developed here, tested here, and it is dramatically reduced trauma mortality.
TUTATA also aligns with national EMS priorities. It supports the implementation of the EMS Policy 2023, which emphasizes the standardization of emergency care.
So we implemented the first phase of the EMS project for a period of 6 years. And the target area was Ministry of Health, Kampala, then we were in Bukoma, Simbi, and Masaka. Then the goal was to contribute to achieving the universal health coverage through improving health conditions of vulnerable communities. We set up a surgical ward at Butenga Health Center 4. We built a fully fledged operation theater. We fenced the entire facility of Butenga Health Center 4 of about 15 acres.
We need money so that we can achieve all this. And the only sustainable source of funding is from government. We are also looking at partner financing. Kofih has already done a lot through the KGA project like this one. It gave us $30,000 US, and this is what has made us come to the point where we are.
National EMS strengthening is an urgent ask to all of us. So therefore, we must take this as a priority.
So I just wanted to, to emphasize the fact that a lot of the challenges that we talk about are everywhere. I've never worked anywhere that didn't struggle to bring quality emergency care to its most vulnerable patients. So I think that remembering that it is actually a global challenge, we can maybe start to think about what some of the tools are that we can draw on across the board.
So as government agencies, please, let's pass the act or fight for the act. Let's fund for establishment of coordination centers for ambulances. And then let's have the EMS cadre that is specific to provide emergency care across the country.
This is not a dream. It is a project plan. Our mission transcends policy. It is moral commitment to safeguard our people. Let's be architects of that system. Let's build with urgency, scale with purpose, and resource with determination. Esteemed development partners, distinguished guests, colleagues, ladies and gentlemen, good morning. We're here today to confront a simple, stark truth. In Uganda, whether the person lives or dies during a medical emergency still depends too much on chance. Our mission is to replace chance with a system, a resilient national emergency medical services that leaves no one behind. Our homegrown Uganda trauma assessment and treatment algorithm, TUTATA, is a proof of what is possible. Developed here, tested here, and it is dramatically reduced trauma mortality.
TUTATA also aligns with national EMS priorities. It supports the implementation of the EMS Policy 2023, which emphasizes the standardization of emergency care.
So we implemented the first phase of the EMS project for a period of 6 years. And the target area was Ministry of Health, Kampala, then we were in Bukoma, Simbi, and Masaka. Then the goal was to contribute to achieving the universal health coverage through improving health conditions of vulnerable communities. We set up a surgical ward at Butenga Health Center 4. We built a fully fledged operation theater. We fenced the entire facility of Butenga Health Center 4 of about 15 acres.
We need money so that we can achieve all this. And the only sustainable source of funding is from government. We are also looking at partner financing. Kofih has already done a lot through the KGA project like this one. It gave us $30,000, and this is what has made us come to the point where we are.
National EMS strengthening is an urgent ask to all of us. So therefore, we must take this as a priority.
So I just wanted to, to emphasize the fact that a lot of the challenges that we talk about are everywhere. I've never worked anywhere that didn't struggle to bring quality emergency care to its most vulnerable patients. So I think that remembering that it is actually a global challenge, we can maybe start to think about what some of the tools are that we can draw on across the board.
So as government agencies, please, let's pass the act or fight for the act. Let's fund for establishment of coordination centers for ambulances. And then let's have the EMS cadre that is specific to provide emergency care across the country.
This is not a dream. It is a project plan. Our mission transcends policy. It is moral commitment to safeguard our people. Let's be architects of that system. Let's build with urgency, scale with purpose, and resource with determination. esteemed development partners, distinguished guests, colleagues, ladies and gentlemen, good morning. We're here today to confront a simple, stark truth. In Uganda, whether the person lives or dies during a medical emergency still depends too much on chance. Our mission is to replace chance with a system, a resilient national emergency medical services that leaves no one behind. Our homegrown Uganda trauma assessment and treatment algorithm, TUTATA, is a proof of what is possible. Developed here, tested here, and it is dramatically reduced trauma mortality.
TUTATA also aligns with national EMS priorities. It supports the implementation of the EMS Policy 2023, which emphasizes the standardization of emergency care.
So we implemented the first phase of the EMS project for a period of 6 years. And the target area was Ministry of Health, Kampala, then we were in Bukoma, Simbi, and Masaka. Then the goal was to contribute to achieving the universal health coverage through improving health conditions of vulnerable communities. We set up a surgical ward at Butenga Health Center 4. We built a fully fledged operation theater. We fenced the entire facility of Butenga Health Center 4 of about 15 acres.
We need money so that we can achieve all this. And the only sustainable source of funding is from government. We are also looking at partner financing. Kofih has already done a lot through the KGA project like this one. It gave us $30,000, and this is what has made us come to the point where we are.
National EMS strengthening is an urgent ask to all of us. So therefore, we must take this as a priority.
So I just wanted to, to emphasize the fact that a lot of the challenges that we talk about are everywhere. I've never worked anywhere that didn't struggle to bring quality emergency care to its most vulnerable patients. So I think that remembering that it is actually a global challenge, we can maybe start to think about what some of the tools are that we can draw on across the board.
So as government agencies, please, let's pass the act or fight for the act. Let's fund for establishment of coordination centers for ambulances. And then let's have the EMS cadre that is specific to provide emergency care across the country.
This is not a dream. It is a project plan. Our mission transcends policy. It is moral commitment to safeguard our people. Let's be architects of that system. Let's build with urgency, scale with purpose, and resource with determination. Esteemed development partners, distinguished guests, colleagues, ladies and gentlemen, good morning. We're here today to confront a simple, stark truth. In Uganda, whether the person lives or dies during a medical emergency still depends too much on chance. Our mission is to replace chance with a system, a resilient national emergency medical services that leaves no one behind. Our homegrown Uganda trauma assessment and treatment algorithm to Tata is a proof of what is possible. Developed here, tested here, and it is dramatically reduced trauma mortality.
Tutata also aligns with national EMS priorities. It supports the implementation of the EMS Policy 2023, which emphasizes the standardization of emergency care.
So we implemented the first phase of the EMS project for a period of 6 years. And the target area was Ministry of Health, Kampala, then we were in Bukoma, Simbi, and Masaka. Then the goal was to contribute to achieving the universal health coverage through improving health conditions of vulnerable communities. We set up a surgical ward at Butenga Health Center 4. We built a fully fledged operation theater. We fenced the entire facility of Butenga Health Center 4 of about 15 acres.
We need money so that we can achieve all this. And the only sustainable source of funding is from government. We are also looking at partner financing. Kofih has already done a lot through the KGA project like this one. It gave us $30,000 and this is what has made us come to the point where we are.
National EMS strengthening is an urgent ask to all of us. So therefore, we must take this as a priority.
So I just wanted to, to emphasize the fact that a lot of the challenges that we talk about are everywhere. I've never worked anywhere that didn't struggle to bring quality emergency care to its most vulnerable patients. So I think that remembering that it is actually a global challenge, we can maybe start to think about what some of the tools are that we can draw on across the board.
So as government agencies, please, let's pass the act or fight for the act. Let's fund for establishment of coordination centers for ambulances. And then let's have the EMS cadre that is specific to provide emergency care across the country.
This is not a dream. It is a project plan. Our mission transcends policy. It is moral commitment to safeguard our people. Let's be architects of that system. Let's build with urgency, scale with purpose, and resource with determination. Esteemed development partners, distinguished guests, colleagues, ladies and gentlemen, good morning. We're here today to confront a simple, stark truth. In Uganda, whether the person lives or dies during a medical emergency still depends too much on chance. Our mission is to replace chance with a system, a resilient national emergency medical services that leaves no one behind. Our homegrown Uganda trauma assessment and treatment algorithm, Tutata, is a proof of what is possible. Developed here, tested here, and it is dramatically reduced trauma mortality.
Tutata also aligns with national EMS priorities. It supports the implementation of the EMS Policy 2023, which emphasizes the standardization of emergency care.
So we implemented the first phase of the EMS project for a period of 6 years. And the target area was Ministry of Health, Kampala. Then we were in Bukoma, Simbi, and Masaka. Then the goal was to contribute to achieving the universal health coverage through improving health conditions of vulnerable communities. We set up a surgical ward at Butenga Health Center 4. We built a fully fledged operation theater. We fenced the entire facility of Butenga Health Center 4 of about 15 acres.
We need money so that we can achieve all this. And the only sustainable source of funding is from government. We are also looking at partner financing. Kofih has already done a lot through the KGA project like this one. It gave us $30,000 and this is what has made us come to the point where we are.
National EMS strengthening is an urgent ask to all of us. So therefore, we must take this as a priority.
So I just wanted to, to emphasize the fact that a lot of the challenges that we talk about are everywhere. I've never worked anywhere that didn't struggle to bring quality emergency care to its most vulnerable patients. So I think that remembering that it is actually a global challenge, we can maybe start to think about what some of the tools are that we can draw on across the board.
So as government agencies, please, let's pass the act or fight for the act. Let's fund for establishment of coordination centers for ambulances. And then let's have the EMS cadre that is specific to provide emergency care across the country.
This is not a dream. It is a project plan. Our mission transcends policy. It is moral commitment to safeguard our people. Let's be architects of that system. Let's build with urgency, scale with purpose, and resource with determination. Esteemed development partners, distinguished guests, colleagues, ladies and gentlemen, good morning. We're here today to confront a simple, stark truth. In Uganda, whether the person lives or dies during a medical emergency still depends too much on chance. Our mission is to replace chance with a system, a resilient national emergency medical services that leaves no one behind. Our homegrown Uganda trauma assessment and treatment algorithm, TUTATA, is a proof of what is possible. Developed here, tested here, and it is dramatically reduced trauma mortality.
TUTATA also aligns with national EMS priorities. It supports the implementation of the EMS Policy 2023, which emphasizes the standardization of emergency care.
So we implemented the first phase of the EMS project for a period of 6 years. And the target area was Ministry of Health, Kampala. Then we were in Bukoma, Simbi, and Masaka. Then the goal was to contribute to achieving the universal health coverage through improving health conditions of vulnerable communities. We set up a surgical ward at Butenga Health Center 4. We built a fully fledged operation theater. We fenced the entire facility of Butenga Health Center 4 of about 15 acres.
We need money so that we can achieve all this. And the only sustainable source of funding is from government. We are also looking at partner financing. Kofih has already done a lot through the KGA project like this one. It gave us $30,000, and this is what has made us come to the point where we are.
National EMS strengthening is an urgent ask to all of us. So therefore, we must take this as a priority.
So I just wanted to, to emphasize the fact that a lot of the challenges that we talk about are everywhere. I've never worked anywhere that didn't struggle to bring quality emergency care to its most vulnerable patients. So I think that remembering that it is actually a global challenge, we can maybe start to think about what some of the tools are that we can draw on across the board.
So as government agencies, please, let's pass the act or fight for the act. Let's fund for establishment of coordination centers for ambulances. And then let's have the EMS cadre that is specific to provide emergency care across the country.
This is not a dream. It is a project plan. Our mission transcends policy. It is moral commitment to safeguard our people. Let's be architects of that system. Let's build with urgency, scale with purpose, and resource with determination. Esteemed development partners, distinguished guests, colleagues, ladies and gentlemen, good morning. We're here today to confront a simple, stark truth. In Uganda, whether the person lives or dies during a medical emergency still depends too much on chance. Our mission is to replace chance with a system, a resilient national emergency medical services that leaves no one behind. Our homegrown Uganda trauma assessment and treatment algorithm, TUTATA, is a proof of what is possible. Developed here, tested here, and it is dramatically reduced trauma mortality.
TUTATA also aligns with national EMS priorities. It supports the implementation of the EMS Policy 2023, which emphasizes the standardization of emergency care.
So we implemented the first phase of the EMS project for a period of 6 years, and the target area was
Good morning. Welcome back from break. I know I'm waiting for the MC
So I really want the MC to be around before I can start.
Okay, good morning, ladies and gentlemen. I've just been informed that I'm an MC for today. I had no idea. So we're going to a new session, and today we'll be having Dr. Atim Dansan, who will be talking to us about the Kofih ID project, achievements, lessons learned, and best practices. Let's welcome him. He's already here.
All right, thank you. Thank you so much, MC. I want to welcome you to this presentation. My name is Dansan Atim. I'm a principal medical officer. I work with the surveillance department. It's called Integrated Epidemiology, Surveillance and Public Health Emergencies. I am equally the focal person for ID project. I hope they'll move the slides. So, the department has got 3 divisions. I'm already on slide 2. Okay. The department has 3 divisions, and our mandate is well stipulated there. But the key mission and the role in the ID project is leadership, coordination, and policy guidance. The department ensures alignment with the national health priorities, oversees implementation of surveillance and response activities. I'm already in the next slide. The next slide. Right. So this is a project which is $8 million US, a project which started in 2022 and is meant to run up to 2027. So far we have received funds for 3 financial years according to Korean calendar, fiscal calendar. So year 1 we received about 116,809 US, and then year 2 we received about 75,616 US, and in the recent one we got about that is not dollars, the last one down is Uganda shillings, about 2.0 billion Uganda shillings, and we have actually implemented in those 3 years. The first year we were able to implement to 99.4%. Then year 2 was 60.5%. This last financial year we implemented to 92.2%, giving us an average of 84.03%. What is the ID project? Next slide. The goal is to contribute to an effective disease prevention and control in this country. But also the outcome is to strengthen early and emergency response capacity to infectious disease crisis in this country. And then the second outcome is to enhance rapid response capacity of lab capacities in central and southwestern region. The outcome are there, well stipulated, about 7 of them. I won't go through that. This project supports the department, which has the 3 divisions together with the regional EOC, but also it supports the Institute of Public Health, as well as the CPHL. So I know there are teams who are here who could have presented. So our performance is aligned to the key outputs and then the outcome. Next slide. And of which one of them is strengthened early and emergency response capacity. With this project, we were able to train about 60 health workers on meningitis, and that was in West Nile. And then we actually supported about 60 participants from the district of Rwenzori on capacity building on EVD, and some of these people, 37 of them, were actually deployed in the last EVD outbreak that we had in this country. We also supported about 13 districts with the 8 regional TOT training participants to Masaka region. And in total, we had about 119 participants from Bukamassimbi and the Masaka district. I know there are people who are from Masaka in the house. But what was interesting was that we improved the timeliness of reporting from 78% to 84%, and then the completeness of reporting, which is key in surveillance. You can't do surveillance without the aspect of complete reporting. That we improved from 76% to 81%, and we were able to maintain about 39 health facilities on IDSR, which translated into about 131 health workers. The percentage is there well categorized into female and then male. We oriented about 1,800 VHTs on EVD and MPOX in the last financial year, and that translated to about 1,294 community MPOX and EVD alerts using the phones that they actually reported on. Next slide. So we also improved the capacity of our governance, epidemiology, and emergency response by procuring about 3 double cabin pickups for the ID project. We functionalized District 1 Health in the districts of Gwen, Mbarara, and Busia. We procured fuel that was meant to support us in the response. But also we functionalized alert management in the districts that we supported. And that actually supported us in the alert, signal generation, verification, triaging, and then response. We did a joint deployment of RRT, the rapid response team in the districts, and that translated into about 167 of them being deployed to respond to EVD and then MPOX. Next slide. So our response, the department is concerned with the public health emergencies and responses. And in that we did respond to cholera, EVD, and MPOX. So the pictures there shows you the team from the department that supported the response to cholera in Chotera in the year 2024, the month of May. We actually helped to contain the situation and reduce on the mortality, and with at least a case fatality rate of about 6.25%. We did support also respond to imported cases of cholera in Germany in the month of January 2024. This we didn't have any fatality, much as we had many cases. The graph down is an epic curve for Ebola Sudan, which we had the case fatality rate of 28.6%. So currently we are grappling with the MPOX, but as a department we are using that support to help us respond to the outbreak. Next slide. So what do? We support signal generation, use of standard case definition in our facilities, and that we look at improving the timeliness and completeness of our reporting. At the national level, we have actually improved greatly in terms of timeliness and reporting for these priority diseases. The priority diseases in this country are about 45 of them, and we have supported greatly in that. And between the month of the month of 2023 to this year in August, we actually improved and increased signal generation, triaging, and verification by about 7%. And the number of facilities in Masaka region that is using the standard case definition for priority diseases have actually increased from 9.2% by 9.2%, and that was from at least 51.8% to 61%. You can see from that please help me, yes. So Bukamassimbi, you have seen a great improvement, and as well as Masaka that the project is actually supporting. And that actually helped us to contain black water fever which was identified in Bukawansimi district, with about 140 cases and a case fatality rate of about 5.7%. So, with the support, next slide. Next slide. So with the support, we were able to develop an MPOX dashboard, which is key in supporting us. And this dashboard actually translates into the DHIS2. You can see from that what the support that we had. Next slide. So year 3 achievements. 1, we were able to functionalize alert management. We did deploy the RRT to support us in EVD and then MPOX. We had MPOX and then EVD outbreaks at the same time. We strengthened community-based surveillance, and then we did support contact tracing and follow-up. So the success stories, one is that we have been able to train VHTs on community-based surveillance and One Health. And that approach has actually helped us to generate signals that have translated into alerts. And some of them ended up becoming events. So with that funding from from ID project. With the collaboration that we have had with UNICEF, we were able to install some of these electronic systems that are meant to support us in responding. I know Patricia could have shared with you the 717 framework, and that's what we are looking for as surveillance, to really improve detection at the community level, whether in the community or at the facility level, so that we meet the first 7 of early detection, and then the next one day or 24 hours for reporting to the next level. And so this has actually helped us to sort out this challenge without a lot of interventions. Then, of course, we are able to integrate some of these systems, and they are interoperable at the moment. Just like each is electronic community health information system is able to communicate with the electronic integrated disease surveillance and response. So you can see from the photo. Next slide. I was actually speaking on, I almost finished this slide. So on your right side, you see a phone that was distributed with the support from the ID project. But down there, we have got VHTs that were trained in Mbale with that same support. And then we actually moved to about 34 districts in this country. We couldn't bring all the photos there. But that's what we did, and that's what the VHTs were able to do. So all this information, you can actually pick them in our DHIS2 and make summaries of them. Next slide. So the practices that we have had, the good practices, is that with this support, we are able to use integrated disease surveillance and response. We have so far trained 94% of this country, but the usage of our information is still a challenge. And to make matters worse, our data utilization is just at 28%. And that worries me and you, that why do we generate information? Of what benefit? And who are the ones using this information? People generate information, whether at the national level or at the regional level, and they want Ministry of Health to be the one telling them that you have an outbreak. A scenario that we had in Namutumba. And the beauty is they say disease of unknown origin. And yet these conditions are with us. It is not about the data utilization, which is very low. So we have also realized that reporting of alerts by the community that we are trained on notifiable diseases is actually key and is very important. Almost all outbreaks start from the community and end in the community. And unless the community actually involved, we shall never achieve more. I always ask myself, what's the importance of trying to have big OPDs, big wards, when we can actually translate that? To me, I think if we had employed our purposes very well, we only need accident and emergency unit and maternity. The rest may not make sense if we improve services in the community. So we were able to train the DRRT, and these are responders, which are very key. We have got regular analysis of the surveillance information, which we intend to have a great impact of our data quality. The quality of our data is still a challenge as a country. Then the use of case definition. We generate a community case definition, and some of these conditions should actually be handled at the community level. Next slide. By and large, we have got challenges in implementing this project, and one of them is the bureaucratic processes which do not support emergencies. Most times people say we don't plan in anticipation. We don't plan that there are going to be outbreaks, and that has been a challenge. And yet we know that these diseases, we live with them. It's just a matter of us knowing the thresholds, that tomorrow we already have an outbreak of malaria, if we can utilize our malaria normal channel very well. So these conditions, we actually live with them, but the bureaucratic processes that we have do not allow us to respond to outbreaks immediately. And that has actually affected the first 7 of early detection. And the detection can actually work well, but also it affects our the detection and also response. Then there's the delayed procurement and supplies of goods and services. This country has many changes in the policy, and that affects our procurement processes. But in those, we have had also how we have planned to mitigate them, and one of them is to work with the partners, the international partners like UNICEF. That actually supported us in the procurement of the double cabins and a few services that we had. Of course, the last one is the surveillance priorities are dynamic. We look at diseases and events, and you will see in Bududa we have got mudslide, which is not anticipated for. You need to bring in OPM, so it is quite dynamic. Next slide. But also we have learned lesson from this project, that a strong integrated surveillance system that has all the systems integrated enhances responsiveness and outbreak readiness at all times. That combining facility-based passive reporting with the community and active surveillance actually enhances early detection, especially in remote and underserved communities. Like in Bukasimbi, we intend to support, I think with the ID project, we are looking at how to support in the next years, junior region. Number 3, that data quality and management is a critical bottleneck in this country. We generate data, we don't use them. And how do you ensure quality when you are not even the user? You are you yourself. So that has been a bottleneck in this country. That the sustained supervision, supportive monitoring, and feedback performance, strengthen the performance and beyond one-off trainings. Our biggest challenge in this country is not capacity, but how to use the capacity built is our greatest challenge. I interacted with a community member whose sample was taken for COVID-19, and up to tomorrow, the result has never come back. And each time they tell the person that wait. So for how long do the community have to wait for their results? Yes, we know that sometimes those samples are rejected because of reasons, but the feedback is very poor as a country. I know there are colleagues from the lab here. Even if the sample is rejected, let's communicate back to the community. Number 5, that cross-sector collaboration and One Health approach integrates human health, laboratories, communities, and partners for timely and effective implementation. We have got different strengths as different sectors or disciplines. So if we combine our strengths together, we can actually implement this project very well. Number 6 is that preparedness, pre-position tools, trained staffs, and network enable early detection and activation during outbreaks. Each one of us is a subject to an outbreak at any time. Look at what happened in Mubende in 2022. Those were purely health workers. And my question is, even if the IPC was not working, what about surveillance? Because surveillance is the high of medicine. You can't use the hand when the eye has not seen. You rather improve the sight and make sure other systems are working. So those are that. The next slide is just photos that shows what we have done as a department with the support, deployment of RRT. We have had time to interact with the professors from Korea. We have had an opportunity to invite VHTs and interact with the Kofih country office. We have done project steering committee meeting chaired by the PS herself, and those are that. So the next slide is about my engagement with with the Kofih. I was a fellow in 2021 in Korea for epidemiology. I've interacted with those professors that came around. This year in January, I was in Korea to see how best we can implement this project. Thank you so much for your time.
Thank you very much, Dr. Atim. We'll take the questions much later. No, feel free to take your seat. Next, we'll be having Ms. Sharifa Nabikande, who will be sharing with us about the project on cancer. And then we'll take the questions as I go. Is she in the room with us? Oh, okay, great.
Okay, good afternoon to you all. Thank you for being here till the last day. By the name of Sharifa Nabikande, I work as a project manager at the Kofih Uganda office, mainly supporting the cancer project. So for the cancer project, just to give you a preamble, we're mainly focusing on improving access to cervical cancer screening. Yes, just a highlight as we go further. So that these will be the components that you'll be seeing in my presentation. Next. Yes, so why cancer matters in Uganda? So cervical cancer, as you all know, cervical cancer is one of the leading causes of cancer-related deaths among women in Uganda. As of the statistics, the source for this is the Global Can, the WHO Global Can. Those who are able, who know about this, is a system you can access online that can be able to use previous data to project and to see, to show how the statistics will be moving. So this is data from 2022. As you can see, cervical cancer, the one in orange, is among the cancer with the highest number of cases among females, but also in both sexes, it's still one that comes out the most. Next. Yes, so this is just a graph to highlight the incidence versus the mortality of cervical cancer. As you can see, still incidence is higher than all other types of cancers, as well as the mortality, which is even so alarming that I think the highest, if it's 53.8, the rate is 53.8, those incidence rate, then the mortality is 40.6. You can see how deadly it is, and also that highlights that most of the clients that come for care come when it's already in late stage. Next, please. Yes, so the main reasons, different studies have been done in sub-Saharan Africa, but as well as Uganda. So the main reasons for the higher incidence and mortality is lack of awareness in our communities, a low coverage of the HPV vaccination, absence of poor quality reporting, poor quality of screening programs, limited access to healthcare services in our health facilities, as well as lack of functional referral systems. So some of these things the project tried to address, not all of them, and we'll be seeing in the preceding slides. Next. Yes, so this just to show you, to highlight that as Kofih, we try to align with the global plans and strategies, however, as well as with the national plans and strategies, so that we focus on what the country sees as priority at the moment. Next. Yeah, still, yeah, national. Next. Yes, so to move on to the cancer project. The full name for the project is the National Cancer Management and Capacity Building Project in Uganda, abbreviated as CANCAP-UG. The goal of the project is to contribute to the reduction of the incidence and mortality rates of cancer through enhancing cancer management system in the country. The general objective is to enhance the prevention an early detection system for improving access to cancer care services delivered in the country. It's a 3-year project, and so far 2 years of the project have been implemented, and next year we'll be moving on to the final year. It has a budget of $3 million USD. Next. Yes, so here is just to highlight the outcomes. The project has mainly 2 outcomes. The first one is to strengthen cancer control governance and advocacy, where you look at revising guidelines if it's something the government needs, or in terms of dissemination, so whatever falls under that, then also the systems. Then also outcome 2 is to improve female cancer care services in terms of screening, diagnosis, and treatment. So we try to look at the whole pathway, so that even when you screen a client, just don't leave them hanging if you find them positive. What services can you offer so that they can be treated? Next. Yes, so the project site and beneficiaries. So this project, as you have seen, it's a 3-year, it's a short time period with limited resources. So it's a pilot project that where we're mainly focusing on Kampala district, Kampala city, Mara city, and Mara district. So we have 3 main project sites, and those are the beneficiaries. We have the women themselves, the other community members, then the health authorities we work with, as well as the health workers. Next. Yes, so I'll be introducing the different projects, the different components of the project, but this slide is just to show you in the 3 project sites, we support a total of 20 health facilities, mainly with equipment, training of health workers, but when we go further into awareness activities and dissemination of maybe guidelines, SOPs, we try to see how resources can benefit everyone. So, but then for equipment, capacity building of health workers, we mainly target these health facilities. Next. Yes, so, yeah, next. So we work mainly with 2 implementing partners, that is the Ministry of Health, Department of Non-Communicable Diseases, as well as the Uganda Cancer Institute. So each of the partners has their designated roles, but we collaborate together to make this happen. Next. Yes, so before we started implementing the project, we had to make a baseline survey in our project sites. We had to know what gaps are there. We knew the problem statement, but however, the specific areas we had to concentrate on, we had to conduct the baseline finding, so that even after we get achievements, we have targets we have set. So in our 3 project sites, so the orange is the percentage of the females that had screened. This was self-reported, that had reported to have screened for cervical cancer at least once in their lifetime. So as you can see, only 35% were able to have screened in our sample size. I think our sample size was around 1,800. Next. Yes, so the different barriers that they reported to be preventing them from accessing cervical cancer screening. As you can see, most of them reported lack of knowledge, not perceiving the necessity of screening, also discomfort with the examination. Next. Yes, so these are just the barriers under the different, those who had never screened and those who had screened, and still you can see lack of knowledge came up on top. Next. Yes, so this brings me to our project components. We have 5 key components. The first one is guidelines and registers. So we try to see how we can support the government to standardize the cancer care practices. So fortunately for this project, we came in a period when the guidelines had been approved, but we're having challenges of dissemination, including funds for printing. So we supported that, printing and dissemination of the guidelines, and then also capacity building of health workers. These are the people that are going to provide the service. So obviously we had to first get the needs assessment to know if they had received any training prior. So we have trained, a number of nurses, midwives, doctors and lab techs, pathologists, the VHTs, the data clerks. So because it's a whole system that has to work together to make sure that this happens. Number 3 is equipment and consumable support. So after the guidelines are in place, the registers are in place, we have trained the health workers. We had to go ahead and make sure that we equip the health facilities with the necessary things that they need to provide the service. Next. Yes, then awareness, like you said, it was a number one barrier for not accessing cervical cancer screening. So we try to conduct, with Kofih support, the partners try to conduct different awareness campaigns. It can either be having posts or EC materials at the entrances of health facilities, also in the different service delivery points within the health facility themselves. Then that's community engagement workshops where we reach out to community leaders, the VHTs, also the community people, so that we have discussions on what are the myths around cervical cancer screening and how do we inform them better. And then the other one is the radio talk shows, where obviously we reach people beyond even our project sites. So the last one is not really a component because everything we do is targeting towards increasing uptake of screening, cervical cancer screening. Next. Okay, these are the indicators. Obviously, you can't do a project if you don't have indicators. That means at the end, you can't know that you have been able to reach where you wanted to go. So for the impact indicators, those at a national level, like the goal of the project, we want to contribute to the reduction in the incident and mortality. So that we can't measure at project level. But then for the outcome indicators, under the output of strengthening cancer control governance, we want to know what proportion of households are aware of the importance of cervical cancer screening or even aware of cervical cancer itself. Then the referral rate of cervical cancer patients who need further treatment, then also the reporting rate of cervical cancer data. Next. Next, please. Oh, previous, sorry. Yes, so the outcome indicators, so these are the key indicators that we have collected data on in the last 2 years. So we want to know the screening rate, how many women have been able to be screened in the different health facilities, then at project site level, then the composite value. Then of those who have been screened, how many have been found to be screen positive? Then those who have been able to be who have been found to be screen positives, those are the ones with the precancerous lesions. We want to know how many of them have been able to be treated. Next. Yes, so the major successes and achievements. Yes, so the 20 health facilities I talked about, 15 of them are health center 3s who have been able to be equipped to function as early cancer detection units in their communities. So through this project, we're trying to bring services closer to the communities that need them. And as you know, the dynamics, the patients, clients are so frustrated. If we only have one national cancer center, then you have regional. So in those facilities, we want to make sure at least the health center 3s are able to screen, and some of them are able to treat the precancer, so that if something they can't handle, then they can refer. Yes, then previously, please. Yeah, so we have been able to screen so far 39,200 women screened across the 3 project sites. And those who have screened, those who have been found to be positive, these are the 2 different methods that we have been able to support for treatment of precancerous lesions. So we're able to know how many women we have been able to screen, but also how many women we have been able to save from getting the cancer itself, the cervical cancer. Then obviously the health worker capacity, like I've already mentioned, we have been able to train different health workers across different areas that can help support the cervical cancer screening. Next. Yes, so another key achievement as a project, but also as a country office, we're able to invite the permanent secretary and also the permanent secretary of the Ministry of Health, but also the executive director of the Uganda Cancer Institute, as well as the high-level officials from the two institutions to South Korea to be able to benchmark. So this is also one of the ways we're trying to strengthen governance, to benchmark, because just something to tell you, cervical cancer was also one of the biggest issues in South Korea. However, over a period of time, due to intensive different programs, it has been able to be brought to a minimum. So it was a benchmarking visit to different areas in terms of policy, maybe health insurance, also the digital systems they have used. Yes, then we're also able to, during the visit, the officials were able to sign a partnership agreement between 4 institutions. The first one is Uganda Cancer Institute, Ministry of Health, Kofih, and then the last one is the National Cancer Center of South Korea. Next. Yeah, so this brings me to, there is a new innovation that was recommended by the National Cancer Center, and currently we already have 2 devices in the country so that the health workers can be able to familiarize themselves with it before we do a validation study. Yes, so as you know, cervical cancer screening and early detection remain a priority under the project. However, routine screening and training often face gaps in visual clarity, standardization of findings. So this device, let's go next so I can explain better. Yes, so this device, it's handheld. Similar devices have been available. So one of the greatest things about this device is called the Dr. Cervicare. It uses AI technology, so it's portable. It can be taken anywhere. In the outreach, during different campaigns, you don't need too much stress to transport it. Then it has a high resolution, instant analysis. Yes, so just to make it simpler, so that device, one of the techniques used for screening is the VIA, those who know. What this instrument helps, it helps to support the health worker to know what they are seeing. Is it right or is it wrong? So the health worker, especially for the lower health facilities, the health worker is able to say, I think I'm seeing a lesion. The machine will assist to see if it's positive, what the health worker is saying, or it's something wrong. If it's something wrong, then the health worker can be able to consult. Next. Yeah, this is just about the software. It also has a feature of teleconsultation, whereby the health worker can be able to receive consultation online with a consultant in the field for further. Next. Okay, so lessons learned so far through the project. System strengthening yields more sustainable impact than isolated interventions. I think Dr. Kalesubla said the government can have capacity to implement without a middleman. One of the things the Kofih projects try to strive is to, that's why it has been government to government. How can we strengthen the system so that they can be able to improve on what they do? Then also she said something of great demand, services have to be available. We are creating awareness by the services in the health facilities. Some community people fear even go to the health facilities. For example, even for small issues like maybe malaria, there is lack of the stock out of drugs. Therefore, when you create a demand of a service, you have to make sure the services are available for the community people. So availability of services directly influences service uptake. Number 2, continuous mentorship is critical for quality service delivery. We have had issues, these lessons of learned are mainly also due to some challenges we have faced. We have trained some health workers, and when we reached the field, some health workers had been transferred. So that also called for continuous mentorship, but also the good thing is because we had trained, we're trying to build a system that we don't have to invest more resources to bring individuals back to Kampala for training. There's already professionals at the regional level or at higher levels within the same project site. So nurses have been finding ways to mentor each other without having to put resources. Then simple integrated data system enable routine use and decision making. For this, unfortunately, when we had these indicators we wanted to track, and when we tried to reach the different systems that could provide this data, unfortunately, there were only 2 indicators that were being tracked. How many have been able to be screened, and how many have eventually developed cervical cancer? So there were missing indicators to track. So the partners came up with a system specifically for the project where the information in the registers was designed in that system, and project sites are able to input data from those sites. However, we're trying to find ways. There's already ongoing discussions of how to integrate the 2 systems so that the efforts of the project are sustainable. Next. Yes, so I think this is my last slide for best practices. So as Kofih, when we think of best practices, we think of 3 main things. Impact. Are the activities we're implementing, do they have impact? Do they help us to achieve what is set out to achieve? Sustainability. Are they sustainable even after the project goes, closes? That's why we try to support the government itself, to strengthen the government system, to work with partners, also to work with leaders in the different project sites, like the district and the city health officials, so that they can own the project. Even after we go, they can own the project, supervise the health facilities, then service delivery, integration, and sustainability. We had issues, challenges where some health workers would not be able to meet the targets that were set out for them. However, when we told them to integrate, we realized the numbers were increasing. So in-service integration, so that cervical cancer is not a standalone activity, but they integrate it into the family planning clinics, the antenatal clinics, and also the OPD. Then the last one is innovation. Sometimes things fail. It's not because we don't do the things, but it's because of how we do the things. How best can we do something to be able to achieve the best of results? Next. Yeah, thank you very much.
Thank you very much, Sherifa. I think we've not truly appreciated the presentation. Can we clap? Thank you very much for that. This juncture, we're going to take the questions. Dr. Atim, please take a seat. Excited to see what people will be saying. Can we take questions from the presenters? Any questions?
Thank you so much. Dr. Tim, for your presentation on epidemiology and surveillance from Ministry of Health. You did present so well, but I have a few issues I'm looking at. One of the challenges that in as much as I think the surveillance, integrated surveillance system has done well in our country, we still have a lot of challenges. And I want to take you on from your statement where you said that our problem is not lack of capacity, but how to use the capacity that we have. And indeed, that's a big problem. I've always asked myself, do we actually use utilize the biostatisticians at the district to the full potential? And every time you want to get data at the district, you start struggling. And the full biostatistician is there, full-time and employed. Then number 2, why would we have the VHTs and then we struggle to get data in the village? You have about 4 VHTs at every village. These guys can even be deployed to do head count. That in every village, we should be able to know, and you are now creating a system, should be able to know how many pregnant women are in a village, because we have VHTs who are operating there. But we can't get that information. And then every time we are running around. When it is reporting time, we are running around to look for data. Every time you are reading a government document, sometimes you find a lot of edits and errors and the copy and the paste without editing, and then you're like, are we serious? We have all the capacity and all the resources that we put in place. So I think we should be able to do better on that. Then for Sharifa, when you presented the project on cervical cancer screening and cervical cancer generally, I was amused and I looked at it, and also look at the resources that you have deployed. But as a person who is involved in those community health work and special screening for NCDs, every time you go to a facility, you want to do cervical cancer screening is at the community level. That's when you find the trouble. They will tell you people somebody is trained, then has gone for another workshop, then has looked at the cupboard where the items are, then she's on maternity leave and people cannot be screened. And then, what do we do with all that investment that you're putting in place, living beyond the project? Then number 2 on that is you present good data on cervical cancer screening. But like yesterday somebody remarked, every woman who is screened for cervical cancer also has a breast. So is it a crime to also put, how much more money do we need to talk about the breast screening for the same woman who have screened for cervical cancer? For the people who are funding all these activities and initiatives, please let's look at that. Thank you.
Thank you very much for that candid evaluation of the presentations.
Thank you very much for the good presentations. For me, mine is just a comment. I love the work that is being done. And looking at one of the slides you shared, which was talking about the incidence and mortality of the top 10 cancers. Most of the projects are focused on women. So when you look at, how the graph flows, we have cervical cancer, which is one of the biggest or the commonest in terms of incidence and mortality. Then we have prostate, then breast. Since we are engaging the ladies, I don't know when your project ends, why not engage the men too? Because we are also victims. Dr. Jethro, I think, wrote an article yesterday, which was saying, well, we should have sex 4 times a week, or ejaculate 4 times a week, or something like that. So I'm just proposing, I don't know what your plans are over the next near future, but I'm proposing, if you can, as you engage the ladies, if there is a way to engage the boys or the men, it would be wonderful. Thank you.
Thank you very much, Dr. Jatho. You have a serious issue to deal with. Any other questions? I think, yeah.
No, response, the panelists will respond, yeah. Thank you so much, Dr. Tim, for the presentation. I just normally have been thinking about the surveillance system in Uganda and also maybe in other countries. When you look at even the alert that you are speaking about, there seem to be diagnostic alert on what has happened. But many of these outbreaks, they tend to have some precursor events that normally prompt them. Let's try to relate it to landslides. They will tell you, there's some cracks here on this mountain, maybe whatever thing, Elgone, that in a subsequent rainy season, when it rains heavily, you like to have a landslide here. Are you doing, is there a way of building such system also, where we can be able to prompt that there will be a likely event, so that action is taken earlier, or the readiness is much earlier, to avoid devastating effect when the actual event occurs?
Thank you, and allow me also just inquire about this new technology, Mr. Rifa. Is it available to other organizations that are doing screening, or is it specific to the Kofih project? Thank you.
Yeah, thank you so much. I think there are 4 comments. 2 were not for me, but 2 were to me directly. Comment 1 is about the use of biostatisticians in our healthcare system. These are very resourceful people. And if we actually employ them rightly, is our greatest advantage. The only thing I think we have as a challenge is job schedules versus job descriptions. The job descriptions are very clear, but when you go to the field, because Ministry of Health has no direct mandate on restraining these people, you will find the biostat has been assigned a duty of a district planner. It has happened. So, and we don't hold it directly. Our work is to advocate that people should actually be deployed on what they know best. But I think we have made some stride. We are moving forward that. If the DHOs are the rightful DHOs, even the DHOs, you'll find somebody is acting even when he's qualified. When you are acting, you cannot take certain decisions because you are not binded by your authority. So I think this is a good guidance. We'll look into this as a department and see how we can support the biostat together with its surveillance focal person, because we need data. Surveillance is all about data. So we have taken that. Then the concern about VHTs is true that even in the healthcare setting, most times the data that are generated are lost. Even right now, if you go back to look at the data to do with Ebola that we had recently in January, I don't think our community members can actually even have how many contacts did they follow, how many people were positive and they were actually discharged after being quarantined. So, but the support that we are getting together with other partners, Kofih has supported us to identify these challenges, but with the support from other partners, we are looking at the digital way of keeping information. I know it has got also challenges, maybe like when the system corrupts, you can lose out all your information, but that is better than the paper-based, which can be burnt in a BVHT's house, and tomorrow you really want to get the full information and you can't really access them. But I think that is one way we are going to. We, first of all, feel that VHTs are the primary team that we should actually use and work with to identify these challenges in the communities, and also support us in the response as well. The third comment was directly to me, alert, that we support. Yes, we have identified most of this, Doctor. Our big challenge has been how we can collaborate with the other sectors. We are trying to strengthen One Health approach. And remember, the One Health approach is a platform where we can all, I have seen this, but I have no mandate. In this country, mandates are, the mandate to keep Ugandans healthy lies with the Ministry of Health. But when you see response to like mudslide, they'll tell you OPM has got Ministry of Disaster. So if we can actually strengthen our platform, the One Health approach, I think that we shall be good to go. We have had scenarios, because they do not know that a mudslide has got the health impact. If houses are buried, the toilets are buried as well, tomorrow you end up with the cholera, diarrheal diseases, and so on. So I think you are right. We have had challenges in working with the One Health approach because the strategy has not been very clear, but also the guidelines and the manual on how we operate has never been very clear. I think it should be bottom up so that we actually improve on this. Thank you so much.
Thank you for the questions that were raised. So the first one was, what happens when a health worker who's supposed to be screening goes on leave and keeps the equipment with a key? Yes, so that affects the screening, obviously. So, however, initially we were training 1 to 2 health workers per facility so that we don't disrupt the routine service delivery. But however, we've been doing mentorships, and then we're also training more. We're trying to see that more health workers within each facility, midwives and then the nurses, at least each one of them has an idea, has the confidence and the capacity to screen, so that if one goes on leave, one can take over. If one, yeah, so that's how. So the equipment is not allocated, is not given to nurses, it's given to a health facility. And the health facility and in charge is the one that has the mandate to keep the equipment. So even in addition to that, So the in-charge is answerable, but also has the role to make sure that screening goes on, because the project is supporting the routine work of the health workers. We're not bringing anything new to the table. But also we're working with the district health officer so that in case of any issues, they can support supervision, but also to try to address some of these challenges. The second one was every woman that is being screened obviously has a breast. And screening for breast cancer does not need any equipment. Our partners tried Ministry of Health and UCI. I have been continuously advocating and talking to the health workers that if a client comes and you're screening them, kindly also look out the breast. So this has been in our awareness programs. Yes, we don't support equipment and all those things, but because it's a project, we're trying to stay focused so that we can be able to look at the results and it's clear to measure. But for the breast, in terms of awareness, so for awareness, we look at different cancers. Sorry, that didn't come out in the presentation. We look at the cervical, the breast, the prostate, and the other cancers that can be preventable. For the awareness materials with the supported development and dissemination, we look at the different cancers. So that if we can't support in treatment or screening, at least we can support in the primary prevention of the other cancers. Then the other one is why not engagement in prostate cancer. Yes, this has also been coming up in the different project sites. Yes, we're supporting women. What about the men? Because it's a pilot phase and we're trying to see which areas can we put resources and how can we get the impact out of it within the short period of time. But then prostate is on the table. It's something that is being discussed, and we hope that if we have the second phase, we can widen the scope and be able to support at least even the men. So that's something that is in discussions. Then the last question was, is the new technology available for other institutes or it's only for the cancer project? So currently we have only 2 devices that were lent to our partners to get familiar with them, to use them. However, we urge the partners, especially Uganda Cancer Institute, to be able to introduce the device to maybe other institutes and faculties, most especially the Gynecology Association, so that all of them can be able to interact with the device. But then also under the next year, we're trying to procure more devices so that we are able to carry out calibration and validation study to see is this something, so that we can have research and then document our findings so that the Ministry of Health can be able to take it up and maybe scale it. Thank you very much.
Thank you very much to our speakers. Let's appreciate them. Some of you are not appreciating. I wonder why. You didn't like the presentations? Thank you very much, Dr. Tim, Ms. Sharifa. At this juncture, I would say this session is nearly closed. We'll be having a brief energizer from Ms. Susan. Ms. Susan, please step up. Thank you. I'd like to assume energizer means we stand up, right? Yes. Get up, please.
Please get up, get some space. So my name is Alobo Susan, and we will just use the opportunity to stretch a bit and address the issues Doctor were talking about this morning. Just a bit of stretching, you know, so we can feel we have exercised a bit. So before we start, the first thing we will do is to breathe in deep and then out, yeah? Let's do it together. Start. Out, yeah. Again, in and out 3 times, yeah? So we can feel it, yeah? You need to feel it that you're breathing in and out. There's a way it feels. It's very relaxing. So after that, the instruction is, my name is ALOBO. We are going to use our body to write it. I'll just show it to you and then we start together. So letter A, we will go in front, back, and then cross. Letter L, we will go in front, down, and then cross from the lower back. And then, yeah, we do round and round. So I'll just put the microphone down so we can do it together. Okay. So let's start. We start with A, go in front. Okay, we start from behind. So go behind and then we go, come in front, make a long stretch, and then back, and then we cross. Yeah, that is A. And then when we do the L, let's start from the front and then we go back, front, and then back, and then cross. Yeah? And so letter O, let's just make a round. For the first O, let's do it from the right, anti-clockwise, yeah? And then the other one will do it clockwise. So let's go round. Yeah, make it a real O. Yeah. And then for letter P, let's start from down. We go backward, and then we come in front, and we go like this. Yeah, and then like that. So the other O, because we did it anti-clockwise, now let's do this one clockwise. Yeah. Round, make a full round. Okay. Then you can open up your hands. Leave it there for a bit. So, yeah, you can close your eyes, feel it. And then you turn your body after you open up your legs. Turn it a long one. And then on the other side, a long one. Yeah, and then you are good to go. MC, please. You can do this in between your breaks at office.
Thank you so much. Thank you for the energizer. I can't forget that sitting is the new smoking. But when you stop smoking for a few moments, you reduce your risk. It's very true. Thank you. We are coming very near the close. The panel that had that was discussing previously, Sharifa, please kindly come forward and you take a picture with your moderator. She needs to remember this moment. As they are taking their picture, kindly, there is a QR code on your table. Please scan it and give us some feedback about how this event has gone. Be as honest as possible so that we can be able to know how to intervene and how we can move forward. The Director General of Health Services will be joining us at exactly 1. So we have a few moments to fill in that form as we wait for him to join online. Please fill in the form, scan. You can use your camera or a QR scanner and you scan. If your camera does not work well, you can ask a colleague to send you the URL. It will also work as well. Can you coordinate with the DG and you see how far it has reached? Yes, let's fill in that QR. And have you gotten the QR code? I don't see anyone scanning on this tape. Collins, please scan. We also need your feedback. The organizers should also be filling in. as we're trying to get the DG, kindly help us with that feedback. So when we've gotten him, we'll be able to move forward. However, it's also important to hear from you and see how your reviews are going. We missed an opportunity to introduce ourselves in the morning. So kindly, I'm going to move this microphone. You just say your name, what you've enjoyed about this forum, what we can do better, and what do you think should be the take home from this event as we wait for the DG to join us. I'm going to start from this table.
Thank you so much. My name is Christopher. I work with Uganda Non-Communicable Disease Alliance, and I've liked this panel. One of the things this workshop I started from day one, and I'm happy that I've come to the end. So I've interacted with people. Some of them are old friends I didn't know, but also it's important to know that there is a lot that has been happening in the backyard. We know most of all these projects we are looking at NCD, at the infectious diseases, but the concern that is being put on non-communicable diseases, I think we thought we were alone, people in NCDs, but I have come to appreciate that some people are actually doing a lot of work for prevention and control. And I've enjoyed this workshop. Of course, learning that making new friends, but also getting in touch with is it Kofih? Is that an organization or it's yeah. Of course, now I know that Ugandan CD Alliance will now have another partner that is supporting the prevention and control of non-communicable diseases. So that's the most important thing I've enjoyed in this, to be part of another partner. Thank you.
Thank you so much for giving me the opportunity to say something. For me, I think I've learned a lot. Then the key important point I've taken here is that our partners should not be fearing working with the government. Give the money to the government, monitor to make sure it does the right job. Should not fear to take things off budget, go yourself in the field, come and give technical support. So I feel maybe next time, you can have more than one partners in the same hall so that we're able to share and replicate this. It will be much better for this country. Then the second important thing is bringing the different constituencies, the different faculties of health in one room. It's very, very important. When you're negotiating for resources, people try to look at what they see in their entity without knowing maybe the infectious disease is having trouble here. It is very important. Without knowing maybe kidney disease is a very important issue. When I see Professor Kalisubra speaking about kidney disease, the other side, the other part of Dr. Riem is fighting for cancer. Or Magino saying it is your heart. For him to tell you when your heart stops, everything has stopped. So you want all the resources, the other side. But if you come here, it is a kind of a concept of the One Health, which is used in the epidemic disease, One Health approach. That every small component of the health matters a lot. If we come and dissect the problem together, we are able to say, me, whether coming from the Cancer Institute, I see even cardiovascular disease. The burden is much higher. If you give more money here, I'm still comfortable. Than saying I need to pull all into my context. And then integrating the level of effort. When you put the resources to the entity that is having a bigger eyes on what is happening, they know where to prioritize that resource much better than when you come as a single entity, blindly. Maybe you go to your Namutumba district, you do your survey there, but you're not comparing Namutumba with other districts. You may be putting more resources in one particular place. Yeah, so I find that is very, very, very important. When you look at the screening prevalence, the commissioner mentioned here, the national prevalence, 23%. That is national. But you have district in Uganda with almost 40% coverage. The survey we did in Mbarara, the Sharifa presented there, 35% screening uptake. Yes, some district in this country may be having less than 10%. But if you share that kind of data, you're able to take a better decision, prioritize the interventions where really it is much needed. And also we have a fair understanding of the economic status of our country, knowing that here, whether you don't put it, maybe they can afford to pay for it. The willingness to pay and the capacity to pay might be much higher than somewhere else in this country. That's the concept I've learned here, and what I feel like we should, I think, continue doing that. Maybe next year, you say, add us more? Yeah, Oliver Twist. Who read Oliver Twist? Add us more. We come and interact in a much bigger way than this. Thank you.
Good afternoon, everyone. My name is Diana Inumugisha from Mulago National Referral Hospital. I'm a nursing officer working in theaters. What I learned here, I think this morning, was on NCDs. And the commissioner stressed about our plate that it should be more vegetables than the meats, the carbohydrates. And as someone who works in theaters, we rarely get such opportunities to interact with the rest of the health workers, the rest of organizations. So to me, this was a great opportunity to come and interact with the rest of the people. And the information I've taken, I will share it with the rest of the population that I work with. Thank you.
Good afternoon, everyone. My name is Atwile Justus. I work at Mulago National Referral Hospital. What I learned from here, what I appreciate from the organizers first is they brought us a lot of most experienced facilitators, and I want to commend that. And the information they gave us, it was so good. And two, the organization was also good. So for me, generally this was a successful workshop. Then the other thing is maybe what I would like to see next year is to bring specialists in digital health, because as we saw, every presenter almost talked about data, and we saw that it was a bottleneck. Yeah, I would want to see like next year if you would bring specialists in digital health and how we could manage our data and keep it safe and share it in a safe way, or manage it in better ways, and have other innovations in digital health vis-a-vis all the components of healthcare that you've been talking.
Thank you very much. I'm Dr. Kariesula from Makerere University. I've learned a lot today about Kofih, and I've also made some new friends, 3 in particular, and I've got their contacts. But also what I learned through the discussions in the corridors is that when we are talking about the cost of healthcare, we should not focus on what is done only at the hospital. The patients, before they even get to the healthcare system, have a lot of associated costs, and we need to begin communicating positively about those. Thank you very much.
My name is Susan Alobo. For me, my take on this is the fact that we don't take seriously the drivers of NCD, because even among us, I've looked at myself, and every day I start thinking about exercise, then I extend the alarm clock. I'm supposed to wake up at 4:30 to start. Probably I'll start at 5, and by 6 I should have gone for work. So the onus is on us to keep healthy, really. It's a big struggle. The truth is our work keeps us at the desk for many hours. Of course, a few of us have the chance to stand. especially those who do real things, like probably the surgeons, they have to stand while they do the surgeries, but most of us, we are sitting, speaking to the clients, yeah, and all that. So, yeah, it's a motivation and inspiration also for me to keep healthy, so I'll do my part. I've already started today, so yeah, I should continue.
Good afternoon. Dr. Mona Alphonse is my name. I'm the president of the KGA. I'm really happy that what we put as a concept, as a thought process, has finally come to reality. Next year is going to be bigger and better. So please keep jogging until we meet next time. Thank you.
Good afternoon once again. Sharifa Navikande, Project Manager at Kofih, our Uganda office. What I've liked most about this arrangement has been the people that have shown up. Some people have taken long without seeing them. Then this has been able to bring, I think also the people you have taken long without seeing, people you went to Korea with, some in other professional dynamics. So it has been able to do that for us. And people have been able to share different perspectives, and then we have learned so much. Personally, I've learned a lot since Monday. One thing that can change may be how we can improve if we make it a hybrid next time, so that we can, I think we have lost out on some key presentations, people that could contribute to this seminar. So if a hybrid is organized from the start, so that people know that this is an option they can participate in. And then the other thing is that the different challenges that have been cited across different presentations, if next time organizers can maybe reach out to different professionals or individuals that have the ability to influence policy and also create a change. At policy level, government, it can be private, yes, I think we'll be able to even leave the room with real solutions instead of still having things that we need answers to. Thank you.
Good afternoon. My name is Zimbabwe. I work with the Heart Institute. First and foremost, one of the things that I have enjoyed is that I had never heard about Kofih before. So it is my first time to interact with you guys, and it has been really interesting. Then number two, I was able to meet some of my classmates that I had not seen for the past 10 years. So I found them here. It was very good. Then the other thing that it is very interesting, that after you have gone through the fellowship program, they still follow you up. Most institutions, they usually don't do what Kofih is doing, which is a very good thing. And the presentations have been wonderful. And the other thing I've noticed is that there is no project which is a small project, provided you're going to be impactful to the community, which is a very, very good thing. Thank you.
Good afternoon, colleagues. Denise Navimanya, my names. I think what I've really taken home from here and what I've learned is the use of data, and that of course starts from the way how you collect it and how you store it and how you use it to make decisions. So because from what has been shared, I've seen that we have been able to see what the problems that are in the community that actually majority don't know, and without data you can never know that there are such a lot of challenges which could need combined efforts to address. So I think going forward we need to discuss how we can strengthen the capacity of data in our country. Thank you.
Good afternoon. My name is Joy Nsisireki. I'm a nurse. I work with Mulago Hospital, particular medical emergency. I'm grateful for having been one of the participants here, because as a person who works with emergency, there are so many things that are picked from here, especially in the NCDs, because always we encounter them, and even the infectious diseases, we've been at the forefront all that time as an emergency unit. And at the same time, there are some take-homes that have been able to pick that I'll add in some of the things that we've been doing, especially in our health talks that we give. There are some other issues that I managed to pick that I'm going to add. I thank you for the organization, and I thank you, Kofih. There are other things that I learned, that the projects that are incorporated in Kofih that I didn't know. Thank you so much.
Thank you. Members, good afternoon. My name is Wamala David from Mulago National Referral Hospital. I also work in the emergency unit. So first of all, being here for 3 days, as you know, working in the emergency unit, it is a crazy place. So at least being here for 3 days has given me somewhat, some relief from the busy schedules we have there. But also there has been a lot to learn here. Very important topics. Health financing, you know, most of the health workers, we are consumed by patients, and we are consumed by patients most of the time, and we miss out on such good information. So being here has really benefited me a lot. And also the aspect of integration, discussing communicable diseases with NCDs is really the way to go. Because even if a patient comes to the hospital with malaria, they have come as a whole. So you need to handle them as a person, not just as a disease. So being here really has not been a loss to me, and I have learned a lot. Thank you very much.
Protocol observed. Good afternoon, colleagues. My name is Kaigo Gerard, a nurse working at medical emergency too. I've learned a lot from the presentations, but foremost is the two-tata thing of 60-60. I think I have to apply this on my daily work. As you know, we have to have a very quick assessment on triage and treatment, stabilizing the patient within the golden hour, the 1 golden hour. So this helps to save someone, either in trauma or NCD. Then my concern has been, I think we have missed out something. Health of the health worker should be a key priority. So we are looking to talk something about the occupational hazards. Something should be discussed more on occupational hazards. We are dying at early ages after work, on retirement, 60 years and you are gone. So let's think about it and talk and research more on occupational hazards. Thank you.
Good afternoon. My name is Joseph Oumo. I work with Ministry of Health. I've learned 2 things. That there are some people who are really informed. Someone talked about healthcare financing, and we're listening, so attentive, that even up today, I still remember that people know their things, okay? And also, if you want to be funded by Kofih, go digital, right? So let's all write projects that talk to digital migration. Thank you.
Thank you so much. Isaac Newton Okeba is my name. And I think what is quite peculiar and what has come out is that we are not looking at a disease when a person comes, but we are looking at a patient, because all our speeches here have circled and prioritized a patient as a whole person. And I believe if we go with that mindset, the health of our population will be a success. Relatedly, picking from Dr. Atim, whereby we need to we need to stop many of these ailments at community level and not waiting to equip. And I think it came out also from the commissioner. Let's not wait to equip where we think we are doing the repair than initial prevention. And I know all of us maybe have driven or being driven, and you know, if you take care of the car before you go to the garage, you have less cost to spend. Just maybe, I like the organization of the place. It is good. It's a good hotel maybe, and then maybe an area of improvement to both the participants and the organizers is where we need to give feedback. We need to give feedback on time. And if participants have feedback to give to the organizers, give them right here. Don't again go and voice it out there. We will not improve as organizers. Oh, they will not improve as organizers. Sorry to put me in, but I'm part of them. Thank you.
Thank you very much. Joseph Malinga. I do a lot of work sometimes with Mr. Chris and NCDL and East Africa. So for me, there are so many learnings. I've learned something about Tutata and 912 and health financing, and we're always looking at some of these things. One time we did a general analysis of funding for NCDs. So Kenya, Uganda, Tanzania, Rwanda, countries with strategic plans had planned about $800 million for NCDs, but not even a quarter of this was funded generally around the region. So we have gaps there, and there's been so much to learn from some of these sharings. The second thing is friends. Quite a number of friends have been made, and I'm looking forward to more engagements. And the other thing I'm happy about, I've only not just enjoyed, you know, the learnings. I've also walked home with a T-shirt. I hope everyone also has. And that is good for my wardrobe. I will tell them I met some people from Kofih and we learned a few things, and here is evidence that I was there. I'm only hoping that we shall get a channel where we can get the pictures and share with our colleagues back at our offices. And lastly, I'm looking forward to more engagements, probably with Kofih in the near future, and the other partners that do work around the region, and see how we can continue to impact where our effort can. Thank you.
Good afternoon, everyone. I'm Stella Namoya. I work with Uganda National Institute of Public Health. I've liked this health forum. It has been so interactive and well organized, and we really do appreciate Kofih for supporting the KJ projects. Thank you.
Good afternoon to you all. My name is Tezra Rita. I work with National TB Reference Lab. First of all, I would like to thank KGA and Kofih for organizing this forum. My biggest take home actually today was to do with a presentation by Dr. Kali Subula, where he highlighted some of the issues concerning NCDs. And I would say, I think it's true, NCDs are not so much funded, yet they contribute a lot to the mortality in the population. So I think as we look into integration of the different aspects of infectious diseases, integration should also put into consideration the different drivers of the NCDs. Yes, thank you.
Thank you so much. I'm Maria Ankalubo. I currently work with Global Health Advocacy Incubator, but previously, I always tell people over 10 years, over a decade at Ministry of Health. I only left last year. Of course, the beauty about this is, you know, meeting up with people that I had taken long without seeing. But also, this has been evidence that as we serve this country, we must look into the future and not just into ourselves. You know, in most cases, because of poverty, we tend to imagine we are going to solve problems today and that we are going to become rich today. So we forget the bigger picture. What I'm seeing here reminds me of when Kofih opened an office in Ministry of Health in the basement, a very tiny office when they were starting work. And now looking at the billions of money that they're investing in different programs, I mean, it's a manifestation of the leadership that we have at the ministry that foresaw what would come of a very small, tiny office in the basement of Ministry of Health. So mine is just a call that let's be strategic. Let's look at a bigger picture. Let's not look at the charm things, small things, such that we can contribute to the health of the people of Uganda. Because from a very tiny office in the basement and the much impact that they are now bringing forth to the people of Uganda, I mean, this is a big testament for us, and especially those of us who were there when they were opening that office. Yeah, that's what I have to say. More feedback will be shared with Kofih team. I'm more like part of them now, yeah.
Thank you very much. My name is Patience Asim. I work with the Uganda Cancer Society, and we're an umbrella organization with over 40 organizations working in the cancer control space. We are located in Mulago. I am grateful for the opportunity to be here and interact with the different teams. I've been learning a lot because it was highly medical to some level, and a lot of the things, especially yesterday in the EMS section, were things that I was not very familiar with, but I personally enjoyed. In terms of the presenters, they're very well, you know, in tune with what they were sharing about, so that was great, and you could see it in the responses from the different questions that were presented. So it's not just that they were, you know, reading or things like that. So I enjoyed that. Hopefully in the next session we'll have more involvement of the civil society arm. I believe we have a lot to share in terms of the work we do, and also in the different ways we can improve or support some of the work that is being done here today. So I'm grateful for the opportunity. I see we were like 2 of us or 3 of us in civil society. We are a bit disarmed, but yeah, I believe there's room for more involvement and partnership. And yeah, this is me pitching for next year, by the way. Thank you.
Yes, good afternoon, everybody. Once again, I'm Sarah Elayete, and briefly, I think, let me say I have learned much, because you can learn much or learn nothing. But one thing that I have been reminded by one of the key speakers is that each one of us, don't just assume that you're safe unless you're sure that everyone else around you is safe.
Good afternoon, everyone. My name is Barbara Lois Koba, and I'm working with the Uganda National Institute of Public Health. I so happened to learn about Kofih through the 717 e-learning implementation program. And from the IT perspective, I would like to appreciate Kofih for the good work done, especially in supporting Ministry of Health through the One Health approach, whereby they are supporting digital programs that are supporting the entire One Health sector, such that at the end of the day, all sectors of the health empire are benefiting. And I also appreciate the presentations that were made today. They show a high degree of expertise and training that has been taken through the initiatives of Kofih Uganda. And I would I would like to as well encourage digital revolution to continue. People who hope to write for more grants, to write things to do with changing the health sector through technology, digital, because I'm an IT person. And my sincere appreciation goes to Kofih for embracing technology. Thank you.
Good afternoon, everyone. I'm Hilda Tendo Naskombi. I work at the National Institute of Public Health, but I'm also one of the alumni of the Dr. Lee Jong-uk Fellowship Program. I would like to appreciate Kofih for investing in health globally. I have networked, but on top of that, I had great interest in NCDs, and today I should say that the presentations have allayed my fears regarding cervical cancer screening. So I guess one of these days I'm going to be able to take a test soon. Thank you.
Please introduce yourself. Our guest of honor is here.
Okay, my name is Leah Nalwa Gabadiruno. I work with the National Health Laboratories and Diagnostic Services. I've really enjoyed the interactions I've had with other health cadres. I've also learned the state and the innovations that are happening in the different health spaces, such as NCDs, emergency medicine, and the session on health care financing was really an eye-opener. I really enjoyed that session as well. Yes, to cut it short, but I'm also very grateful for Kofih, how they've invested into healthcare in Uganda, and I look forward to the future.
A brief introduction.
My name is Dr. Michael Lukoma. I'm a physician based in Mulago National Referral Hospital. Also here as the Kofih Global Alumni Advisor for Uganda. I really thank the team who was presented today and for the previous days. And I would encourage us in our particular technical areas to get together before we leave today and make sure that your key action plans and recommendations are recorded somewhere to enable us to achieve one of the key outputs for this seminar.
All right, I would like to welcome Sarah. I think you will stand at the podium to give a brief summary and then invite the Director General to close the ceremony. And no, please, we'll do that next time.
A very good afternoon to you all. Good afternoon, are you with us in the room? Yes. Dr. Lara, you're very welcome. We are pleased to have you join us. And I'd just like to provide a summary of, okay. So I'd like to provide a brief of what has been happening in the last 3 days. This is the first Kofih Health Forum. It's been running for 3 days. We started on Wednesday, Thursday, and today is the last day. Our theme has been turning health challenges into opportunities for change. And in this room, we've had key people. We've had representatives from WHO. We've had representatives from Global Health Advocacy Incubator. We've had representatives from the Uganda NCDs Alliance. Seed Global has been with us. Malteser International. We've had Makerere University. We've had Uganda Cancer Institute. We've had the Uganda Heart Institute with us. We have had representatives from Masaka Regional Referral Hospital. We've had representatives from Mulago National Referral Hospital, NTRL, Uganda National Institute for Public Health. We've had OPM in the room. We've also had Ministry of Health, the different departments in Ministry of Health. We've had EMS department, NCDs, and surveillance department join us in this meeting. This seminar has taken the format of, we've had many presentations, about 15 or more in total. We've had question and answer sessions where we have a moderated session with key participants providing some answers to the questions from the audience. And then we've also had group discussions where we've discussed key matters. The forum has been focused on 3 areas, which is EMS, NCDs, and infectious diseases. When we first decided to come up with a seminar like this, we worried about how the different areas would interact, but it has been a very meaningful interaction, and we've had a lot of understanding, and we've deepened our understanding in different areas as well. So this workshop reflects Kofih's commitment to strengthening the health system of Uganda, and even at the inception stage and at the concept stage, we thought that this workshop would strengthen collaboration and partnerships, would be able to share lessons learned from our end as Kofih, and also from other partners that have joined us. We also thought that we'd be able to have a chance to share best practices and then provide some recommendations to government, Ministry of Health, to IPs such as Kofih and others, as well as some critical actions to take from the different institutions. So this workshop has strengthened our collective understanding of the health challenges in EMS, in NCDs, in ID, but it has also helped us to identify some unique interventions that have been in place and to understand the work that's being done by different partners within in the health sector. So especially one of the things that has stood out in this workshop is the understanding of the financial landscape in health. It has opened our eyes to the volatility of relying on donor funds and to support our health sector. And some of the maybe low-hanging fruits that I can highlight from this meeting has been, number one, collaboration and integration. Collaboration and integration remains a very critical part in achieving lasting impact in the health sector. And then number two, we have to focus on efficiency in the face of funding cuts, like the issue of US aid that we're all aware of. But number three, and most importantly, is knowledge sharing is still critical, and forums such as this help us to learn from each other, but also to build our capacity and know what's happening everywhere. So following this workshop, if we invite the partners that are participating in this to a dissemination, we request that you honor that invite. We'll be able to share with you some of the feedback that we've got from this workshop. But additionally, being the first Kofih Health Forum, we hope to organize more in the future, and we look forward to you honoring our invite when you're called upon. And so to summarize, I would now like to invite you, Dr. Lara Charles, our DG, to officially close this seminar. Thank you very much. Oh, Dr. Lara, you're muted, so we're unable to hear you. Kindly unmute so we can listen to your speech. Are you hearing me? Yes, we can now. Hello? We can hear you, Doctor. Please go ahead.
Dr. Charles, sorry for the interruption. Could you kindly turn on your video, please? Thank you, sir. Okay, it's okay, sir.
Resilient health systems. So I want to once again thank you. I know my network might not be very good, but I hope you have been able to hear my message. So thank you, Chair, and thank you for allowing me to give this speech virtually. But I can put my video so that you can see me, though I'm still in the car. So that's how I look like. And I think it's making me look brown. I don't know whether it's towards Christmas. Thank you very much.
Thank you very much, Dr. Lara. I think we can now release you so you can go and handle your other business. We appreciate you.
Thank you. Thank you.
All right. I think after the DG's speech, the event is coming to a close, but I would like to invite the organizing committee back on stage so that they can have a message to give to us as well. Organizing committee, I think all of you should come, each and every other person. I don't want you to wait for Beatrice to arrive and then she invites you.
Well done.
All right. Good afternoon, ladies and gentlemen. All protocol observed. In a special way, I would like to thank every one of us, each one of you, for sparing time to come and spend 3 days here, even as we discuss issues pertaining our health sector. We appreciate all of you for having made time to be here and for all your inputs, for the time you took to do the research in different areas where you're supposed to present, for all the activities that you had at your council to be here with us. We just want you to know that we appreciate you from the bottom of our hearts, and we can't pay you for being here for the 3 days. But from all of us, we just want to appreciate you. Now, before you, my name is Beatrice Orena. I'm leading this team in this activity. This is KGA, Executive Committee. We implemented this activity as KGA, supported by Kofih. So this is the organizing team. I will let them say a word to us today.
Mine is to thank you for your patience. And I'm Hashaka Alex, the General Secretary, KGA Uganda chapter. And we're happy you came. I hope you go back with a changed mindset in terms of being physically fit, your dieting, and everything that you've talked about over the last 3 days. We appreciate you for coming, for honoring our invitations. Please, next year, we hope to have the same, but in a better version because of your evaluations and your comments. So please, we hope to see you next year again. Thank you.
Yes, good afternoon, ladies and gentlemen. My name is Alinda Ruva, Office of the Prime Minister. I'm glad to be here and to be part of the organizing committee. In this organizing committee, I'm in finance, and I think you'll go home with smiling faces. Now, what I want to say is we come from different backgrounds, EMS, infectious diseases, and what's the other one? Communicable diseases. But I would want you to put at the back of your mind multi-sectoral approach, because health doesn't stand alone. You can ask Dr. Alfred, he will inform you. We are with him all the time, cancer, yes, and TB. Those are the ones that I really know, and HIV. So if the rest could also, EMS, please, come on board, and then we move together, because it's a whole government approach. Thank you once again.
Good afternoon one more time. Dr. Mona Alphonse from Masaka. And I'm also the creator of the Uganda Trauma Assessment and Treatment Algorithm. And I'm here to remind you that in the coming year, we will be organizing the annual Tutata Run to create awareness and generate funds for our self-sustainability to train 10,000 health workers in Uganda. Thank you.
Thank you. I'm AU Patricia from the National Institute of Public Health, Ministry of Health. So I appreciate the team for keeping here for 3 days. Not an easy task. And I hope the recommendations, the actions that we got from this meeting won't be kept in our laptops, but we shall implement this. Then we can reassess ourselves the next time we have such a forum. I'm one of the advocates for digital health innovations. So in case someone has some ideas, AI, etc., I will be happy to be part of that team. Thank you.
Yes, good afternoon. Collins Jackson Mpamani. I work with Uganda Cancer Institute. So cancer is the thing, right? In here, everyone is marketing their side. apart from the opium that is marketing money, right? So we are happy to be here and to make sure that this activity happens. I'm sure it is still happening. After here, we shall have a side room for more meetings to discuss with you. But what I'm passionate about is cancer prevention. And in this meeting, I'm an events person on this committee. So most of the pictures being taken, coverage, it has been part of my effort and the rest of the team. And what, he said cameraman. So what is most important for me in this event was the civil society involvement. I tried to make sure that we have civil society brought on board, because these are people that ask hard questions. They tend to be in opposition for the health system. Now that they are on board with us, they are going to give the way of protecting the gains. I am happy that Chris mentioned that he is happy to have added a new partner. Please don't leave before getting the connections. Lastly, everyone who came, please, we shall knock on your door next year. We intend to make this an annual event. Now that I'm in events, now I've seen your faces. Next year it will be better than the way it is today. And we shall continue to invite other new people, but most importantly, we shall reach to you to give us advice on the most technical people to invite for activities like this. Thank you so much.
Good afternoon to you. My name is Regina Mugisa, and I work at the Mulago Specialized Women and Neonatal Hospital. So I'm here also, I'm advocating for the maternal and child health, as others have talked about, cancer and so on. It's an area which I would wish in the next seminar we also address that. In this capacity of the executive, I'm the treasurer. So as earlier mentioned by the finance person, indeed you'll go with smiling faces. Then I would also like to talk about, I'm also one of the team lead in a project for KGA. It's a research project which was accomplished last week, the kickoff meeting, and it's about an integrated study on emergency medical services and medical equipment management. This will be done in Barara and Masaka. So you're all welcome when I come forward to, and when I need your advice, kindly be available. Thank you so much.
Thank you. My name is Dr. Michael Lukoma. I'm a physician based at Mulago National Referral. In this capacity, I've been the Kofih Global Alumni Advisor to the Exec Committee. I also have serving as a rapporteur. So I really want to thank all of you for attending. And we're also so grateful to our sponsoring organization, Kofih, and all its partners in Korea. One thing that you understand from the Koreans is they demand excellence, they expect excellence. So a lot of what you're seeing is so directed from the wisdom, advice, and philosophy that they've been sharing with us to enable us to reach this stage. I also want to thank all the speakers that we called in and who were able to attend. It is really an honor to us that you came and did your presentation so excellently and shared your knowledge. One thing I would like to share, similar to what he said about civil society. One thing I've learned from my mentor, Dr. Kale Subula, is that when you attend the Uganda Kofih Foundation, the Uganda Kidney Foundation meetings, they usually have a patient present. So you'll have a patient who has had dialysis, who has had kidney transplant, and they talk about the struggles that they went through. This is something I wanted to emulate here. So I tried in my several phone calls. I talked to Uganda National Cancer, NCDA, different organizations I talked to, but they were sending their execs. But I kept pushing them. I said, but I actually want a patient. You know, so I think one way we can improve next time is actually, it's great to have the civil society representatives, but we also want the patients who interact with these health services to speak for themselves, and we hear from them what challenges, because they are key stakeholders. If you look at the WHO framework, the patient population is a key stakeholder. So my final encouragement to all of you, whatever you've listened to today, look back at your clinical space, look back at your office, look back at your organization. Like Diana was telling us, in your surgery, are you actually following the surgery checklist to ensure that all your surgical patients, that someone's limb is not removed when they're supposed to be going in the brain? So this concept and this conference or forum is only as useful as you go back and advocate for the NCDs like Dr. Kalisova told you. It's almost not useful if we just leave these ideas on our laptops and we leave them for talking, but don't put action. That's my recommendation to everyone.
Thank you very much, organizing team. I just wanted to say something small about this team. All these guys, I can say they are my bosses. So, I'll give you a scenario. So, it's been a thing of like trying to draw a line between having to see you as a boss and having to see you as a lead of the organization of this activity. So it's been an honor, a learning experience from you. I appreciate you all for the efforts that you've put, the nights that we spent organizing these event meetings. I don't take that for granted. May God richly bless you all. So, and then from the organizing team to all the people who have been here today, we deeply appreciate you. And in a special way, we would like to say thank you to Kofih for seeing this as a very important thing, reading our hearts that we put in that proposal, and seeing that this is really a proposal or an idea that is going to benefit Uganda. For this, we just want to say thank you very much. We can't thank you enough. But from the bottom of our hearts, we just want to say thank you. And to all of you, we thank you so much for being a part of this. Without you, this wouldn't have been possible. So we appreciate you. Kamsamida. Thank you so much. Asante sana. Eyalama. Afoyemate. I don't know where you come from, but I've spoken your language, even though you've not heard it. I just want to say thank you.